interesting.
Oh, this is.
I got 4 hours to get there.
I was thinking it was water, but so sorry. Oh shoot! You take it. There you go. There's no water here actually, so I can tell her. Oh, there's a little. Oh yeah, yeah. Thanks. Okay. Oh, that's a little full, but anyway, let me. It's very hard to see.
Yeah, the lights are so bright.
Yeah. But actually, it seems like mostly people are getting settled. Yeah. Yeah. Okay, we're going to go ahead and get started. So I'm Dr. Brian Dury, and I'd like to welcome you to this year's session on myeloma, approaches to achieve the best possible outcomes in myeloma. So I'm Dr. Brian Dury from Cedars-Sinai in Los Angeles. Immediately to my right, I'm pleased to welcome Dr. Shaji Kumar from the Mayo Clinic. And yes, please. So we'll measure the claps now as I go down, okay? So these are not quite in order. We'll skip Philippe for the moment. We have Dr. Tom Martin from UCF in San Francisco.
Thanks.
We have Philippe Moreau from Nantes in France. Yay! And then next to him on his right is Vincent Rajkumar from the Mayo Clinic in Rochester, Minnesota.
Vincent.
Hey! We are very pleased to have a fantastic panel back. We are all quite disappointed that you cannot see in front of you here Jesus San Miguel, who unfortunately is not able to be with us at ASH at all this year. And so we are very concerned about that and wish him the best. So what is the format? The format, for those of you who have been here perhaps for a number of years, is very similar to what we've done for those years. Each topic will be discussed. There will be a case presentation, so each topic will be case-based. And you may have noticed, for those of you with a chair in front of you, that you do have your keypad, which is there for your audience responses. You just press the button. Whatever button you press last will be your final answer. If you're not having a chair in front of you, you may actually be sitting on your response device. There will be a second voting that occurs as we go through these cases, and so you will see what our experts have to say, and then you'll listen to their presentations, and then you will have a chance to vote again. The sessions will all have a panel discussion, and so the way it will work is that the panel discussion will occur after each topic. There will be more open discussion at the end. At the end, as we've had in the past, we will have the recommended algorithms, and there will be time for discussion about those this year. So, first of all, a few quick polling questions. So just let us know who you are, physician assistant, nurse practitioner, pharmacist, or someone else. I guess no music for these. Normally we have music. There we go. All right. Okay, so most of you are physicians, a few other allied health professionals. Okay. Nurse practitioner, not too many nurse practitioners. Okay, let's vote again. What is your... some descriptions are mixed, so just pick the one that best describes your current practice. So some VA hospitals are actually academic. Okay, so dispersed. All right, very interesting. So where are you from? Yes. We know from the past that many of you are actually from Europe, and it'd be interesting to see how many this year are from Europe versus Canada, different parts of the US, or Asia Pacific. Okay. Yes, Europe. And then different parts of the US. So actually Europe, Canada, and the Americas, more than the US. Interesting. 9% from Asia. Okay. So how active are you in managing myeloma? How many patients would you typically see per month? This is interesting and helpful for us. Okay, so 30% see quite a bit of myeloma, and yeah, most see at least a significant amount. So this is great. So these sessions are definitely intended to help with what are pretty complicated questions these days. All right, so let me just go quickly through the agenda so you have a sense of what we will cover today. We will start off with diagnosis and risk stratification, and Vincent will present for Jesus San Miguel. We'll then move into how upfront therapy has evolved for transplant ineligible patients, and that will be presented by Shaji. Upfront therapy for transplant eligible patients, and then including consolidation and maintenance. This will be presented by Philippe. And then Vincent will come back and will present the current therapeutic landscape for relapsed or refractory myeloma, and the future directions, which kind of merges with the relapse therapy, will be presented by Tom Morton. And so those two presentations will be presented back to back with a joint discussion at the end of those combined sessions. And then, as I touched on, at the end, we will show our proposed algorithms for 2020. This year, it'll be a little different. We'll show the algorithms from the US perspective, and then we will also show algorithms from the European perspective. And so we think this could lead to a little bit of discussion. So without further ado, I'd like to invite Vincent to present the diagnosis and risk stratification for plasma cell disorders, to treat or not to treat. And so please welcome Vincent.
Thanks so much, Brian, and thanks to all of you for being here. It is really I'm really sorry that Jesus San Miguel is not here to give this lecture. He prepared the slides and I have not modified it much. We're just going to work off his slides. But before we go on to the talk, I just want to go ahead and present a case to you. This is a 51-year-old asymptomatic woman found to have an IgA kappa paraprotein, M spike 1.2 grams per deciliter, free light chain ratio, renal function, hemoglobin, everything is normal. So the first diagnosis was MGUS and the patient was followed. During follow-up, 3 years, she remained stable, at which time she consulted a myeloma expert. At that time, the M spike had increased from 1.2 to 2.3 grams per deciliter. The free light chain ratio had gone up to 25. She had Benz-Jones proteinuria 500 milligrams per 24 hours, bone marrow biopsy 28% plasma cells, of which 97% were clonal cells, and there was a 414 translocation. CT scan was negative, but the MRI showed one focal lesion. So a diagnosis of smoldering multiple myeloma was established. So the question is, let's vote now on how you would manage this patient. Would you recommend observation alone? Start therapy with lenalidomide alone, lenalidomide and dexamethasone, lenalidomide, bortezomib and dexamethasone, daratumumab, or not sure? Please vote. Okay, we have a third of you saying just watch, and then 25% are ready to treat with full-blown myeloma therapy, and everybody is in between. So this is important, and this is great because this is the type of discussion we need to have. And at the end of this, I'm not sure how much this is going to change, but let's see. So this is how the experts voted. We were also like you. Two of us said Lendex, two said bortezomib Lendex, and two were very honest and said unsure.
No, the others are honest too.
There's one more question. This is a little bit more complicated. Let's say we know about this patient, 2.3 M spike, no crab features, one MRI focal lesion. I'm giving you another patient Dr. San Miguel has picked. The same 51-year-old, asymptomatic, 2 grams M spike. There is no 414, but instead of the 414, the patient has imaging which shows lytic lesions in the skull and one in the clavicle. Question is, who is at greater risk in terms of survival? The patient with the 414 without any lytic lesions, or the patient without the 414, case B, with lytic lesions, or you think both have similar risk, or you're unsure? This is a test of honesty here. Wow. So 40% think that the person with 414 is at higher risk of inferior survival. 34 say case B, 13. Here's how the faculty voted. So I'm going to move to the faculty. And totally unsure. And these were really taken without each of us knowing how the other is going to answer. So let me just walk you through the presentation, and then we can go through these cases again. Before we start on smoldering multiple myeloma, I'll start with MGUS. MGUS, or monoclonal gammopathy of undetermined significance, as you know, is present in 4 to 5% of the general population over the age of 50. That means some of us here have MGUS. On the left-hand side, you can see that the International Myeloma Working Group in 2014, with the revised diagnostic criteria, classified MGUS into 3 types: the non-IgM, light chain, and IgM type. Each one has a different problem. Non-IgM tends to progress to multiple myeloma, whereas IgM tends to progress to Waldenstrom's or non-Hodgkin's lymphoma. If MGUS only caused myeloma and Waldenstrom's and amyloidosis, that itself would be a major public health problem. But MGUS is also a culprit in a number of other disorders, like light chain deposition disease, neuropathy, cryoglobulinemia, ITP, acquired von Willebrand's disease. So there's a lot of clearly M protein related disorders caused by M protein that are now recognized. For example, 50% of patients with membranoproliferative glomerulonephritis, the cause is monoclonal protein. So there's new terms like monoclonal gammopathy of renal significance and neurologic significance and clinical significance being developed. In addition, MGUS is kind of vaguely associated with a number of other medical problems where you cannot pinpoint the cause. Like, for example, patients with MGUS are at increased risk of vertebral fractures. They're at increased risk of deep vein thrombosis. They're at increased risk of infections. So MGUS is a clinical problem that most of us face, which has multifaceted problem. But overall, its main significance is that it can progress to myeloma at a rate of 1% per year. Bob Kyle has studied this and he has updated this in 2018, and you can see 1% per year persists, and this curve has been extended now up till here to 40 years. It's always 1% and it's there throughout. If a patient has been stable for 30 years, the next year they still have a 1% risk of having myeloma related disorder. Smoldering multiple myeloma is a different problem than MGUS because instead of 1% per year, now you're dealing with a population that has a 10% per year risk of progression over the first 5 years, after which it slows down to 3% per year, and after 10 years, it becomes more or less like MGUS with 1% per year. So this is a different problem. It was first described by Bob Kyle in 1980 in the New England Journal of Medicine, and we have learned a lot about this disease. When Bob first described it, the concept was smoldering multiple myeloma is like an in-between stage. It is in between the benign MGUS and the full-blown malignancy of multiple myeloma. It's something that is smoldering, ready to move. Now our understanding is different. We have a paradigm shift. We think that smoldering myeloma is an artificial clinical condition comprised, let's say if you have 100 people, 50 of whom have MGUS, 50 of whom have myeloma. You just don't know who's who. And therefore, we're just calling them as smoldering myeloma. If you follow them within the first 5 years, the myelomas will declare themselves. They will progress. After 5 or 10 years have passed, what you're left behind is only MGUS, and therefore the progression rate becomes only 1% per year. This is an important paradigm shift, and it tells you why we are ready to treat some of these patients. It's not like we are dealing with an intermediate pre-malignant condition. We are dealing with a problem where half the patients in this subgroup that we call smoldering actually have myeloma. We just don't know who's who. The first step we did to rectify the problem was to take away the ultra high risk, the patients who are at 80% or higher risk of progression within 2 years. That's 40% per year. We moved them and called them as multiple myeloma in the 2014 criteria. But that still leaves behind a significant chunk of smoldering myeloma in the same smoldering myeloma bucket. We still need to know who are the people who won't progress as much and who are the people who are going to progress 50% or more like risk of progression within 2 years. This is the group that we need to identify. In the old days, this was done by the old Mayo classification, more than 3 grams, more than 10%. That's this group. Or by the Spanish classification. These are the criteria that were used in the old clinical trials, including the Spanish clinical trial that looked at Lendex versus observation. But these criteria have limitations because they classify only a small number of people as high risk, and there are some patients who don't actually progress as much. So the Mayo Clinic came up with a 2-20-20 risk stratification. Basically, more than 2 grams M spike, more than 20 for the free light chain ratio, and more than 20% plasma cells. If you have 2 or 3 of those criteria, that's high risk smoldering myeloma. And last year, actually this year at ASCO, the IMWG validated these criteria in a study of over 1,000 patients. And you can see the high risk group, which has 2 or 3 of the high risk factors, comprises about half of the of the overall group and has a risk of progression of 5.63. Now, if you know, in addition to that, if you know the cytogenetics, for example, 414, which is a known high-risk cytogenetic, that risk goes up even more to like 60% risk of progression at 2 years. You can refine this even more because not all risk factors have equal hazard ratio. So the IMWG presentation that Dr. Mateos gave at ASCO also had more detail by putting up a risk score depending on how much the free light chain ratio was abnormal, how much the M protein was high, how much the bone marrow abnormalities were, and the fish abnormalities. For example, the patient that we saw with a 2 grams M spike, 20 plus free light chain ratio and 28% bone marrow plasma cells and 414 will have a score of 11, which will be right in between these two curves. Not quite 50% risk of progression, but more like 60% risk of progression. So this criteria allows you to more or less refine and counsel your patients more accurately because they want to know, doc, what is my risk of progression? And instead of giving them a rough guess, you can more or less precisely tell them what the odds are going to be. There are several other additional factors. For example, this is a snapshot in time. If the M spike keeps going up or if the hemoglobin is falling, evolving would be another risk factor. Circulating plasma cells, gene expression profiling, you can use this to refine this further. The question in smoldering myeloma has always been, and I'm talking since the 1960s, should we treat or not? People have tried melphalan, people have tried thalidomide, people have tried bisphosphonates, chemotherapy combinations. Generally, nothing has stood the test of time. And the main reason has been that, number one, we didn't have good biomarkers to tell who's likely to progress and who doesn't, and now we do. Number two, we have always been worried about harm. We don't want to harm people who are completely asymptomatic with therapy and the risk of clonal selection. The question is, are we there now? We are learning now that some people with smoldering are more or less myelomas who are going to get myeloma within a year or two. Should we just consider treating them early? And one of the key reasons why we have not treated these patients is the data was scant. There were hardly any clinical trials, and the clinical trials were not of good quality. Now, if you do a PubMed search or clinicaltrials.gov search, you will find that there are 50 trials going on for smoldering multiple myeloma. Trials with single agent, trials with doublets, trials with triplets, randomized controlled trials, single-arm trials, even trials like Ascent and Caesar, which are trying to cure smoldering myeloma, which are trying to cure myeloma with full-blown, not only myeloma-like therapy, even more than myeloma-like therapy. Some of these trials, we already have data. Some of them, data are coming. The two randomized trials that have been done recently are shown on this slide. This is the Spanish trial, presented first by Dr. Mariví Mateos in the New England Journal of Medicine in 2013 and then updated in 2016. What she found was that there is a 75% reduction in the risk of end organ damage. Here, the progression-free survival is not defined by M protein going up. This is actual end organ damage. You reduce that by 75% by using lenalidomide and dexamethasone. And not only that, you also improve overall survival. This trial showed this in 2013. We are in 2019, almost going into 2020, and the standard of care did not change, even though a survival benefit was shown. That tells you how much diversity of opinion there is among the experts and how we are still arguing amongst ourselves whether or not we should treat smoldering myeloma. But the trial that showed a survival benefit had one problem, which was that it used Lendex, so it was not a regulatory study. Number two, it didn't image patients adequately at baseline, so people thought maybe some of these patients had myeloma. A second trial that Sagar Lonial led for the ECOG group has now been published, which overcomes these two deficiencies. It's been published in the Journal of Clinical Oncology last month. And what we found was a very similar reduction in the risk of end organ damage. But so far, there are only 6 patients in this study who have died, 4 in observation and 2 in lenalidomide arm. So it's very difficult to tell what the effect on overall survival is going to be. This is all that we know. There are many phase 2s going on, Elo-Lendex, Ixa-Lendex, daratumumab, There's a phase 3 with daratumumab that has been completed and results are pending. The ASCENT trial is ongoing in the United States, which uses KRD DARA, and that is led by Dr. Kumar. The CAESAR trial uses a very intense curative approach with induction with KRD, transplant, consolidation, and maintenance. This trial is going to be presented again this ASH, and I encourage you to go for that session and listen to that presentation. The trial is showing an MRD negative rate of about 63%, but more importantly, 94% of patients are progression-free. We don't know whether or not this will be the right thing to do. There are side effects to consider, but so far it looks like it's manageable in terms of adverse events. The real question, because of the diversity of opinion, is, and this is not my thing, but I completely agree with this. This is what Dr. San Miguel wrote. Should the doctor decide for the patients, or should the patients decide for themselves after the appropriate information, which is this is all the data we have. It's going to take years before we know overall survival. Should you decide for me, or should I think about the pros and cons and decide for myself? I'll close with Dr. San Miguel's closing slide, as he wants to acknowledge the huge number of hospitals in Salamanca, Navarra, all of Spain, which have contributed to the studies, as well as the International Myeloma Working Group, which has multiple people here you can recognize. And so I will close with this slide. Thank you very much. Should we do the case? We'll do the case and then we'll go to the panel discussion. Let's just return to the case here. This patient that I just told you with 2 grams M spike, more than 2 grams M spike, more than 20 light chain ratio, 28% plasma cells, 414, and 1 focal lesion on MRI. Let's vote on what you would do. Go ahead, start the timer. The music. Okay. It looks like most of you would now treat, unlike the first prior to the session, and so we'll sit and have a discussion on this. So it looks like the number of people who would watch the patient without therapy has dropped from 36 down to 21. Versus about really 65% would treat with either Len-Lendex or with the triplet. So we can have a panel discussion now, and I'll ask Dr. Dury to lead the panel discussion.
So thank you so much, Vincent. Very interesting to see the difference in the voting after your presentation. A shift towards something which actually you don't personally recommend, I think. But do we have any comments from our panel members about Vincent's presentation? Do you want to give your perspective on how to manage smoldering? Tom?
We'll see. I voted unsure for 2 reasons. And one is with smoldering myeloma, and Vincent said this. Taking a snapshot and trying to make a decision at that point in time is very difficult. I think we all should get comfortable in being able to follow these people closely every 3 months for at least the first 6 months to 12 months after their diagnosis. I'm kind of a lumper in this scenario. They either have MGUS or they have active disease and should be treated like active myeloma. In this specific case, the 1 bone lesion, I always get worried about 1 bone lesion. Is it really myeloma or is it something else? And so I would go to my radiologist and I would go over all the examinations. And if it was confirmed that I think that was certainly a myelomatous lesion, then I would favor actually going on to treatment.
Right. I would have to say that my perspective is somewhat similar. You saw the picture from Vincent with the black coals of MGUS and the active flames of myeloma. I think that to the best of my ability, I try to classify patients into one of those groups, and I feel if it's more towards those active flames, that was why I selected to actually treat the patient as if they had myeloma. Any comments?
So the two things that I will tell you is that, I'm a data-driven person. It's really nice on paper to say we'll follow these patients. That assumes that you can catch the end organ damage in time. In reality, that is not going to happen. I'll tell you why. In the ECOG trial, patients in the Smoldering lenalidomide arm as well as the patients in the observation arm were seen every month. And we still had, in the high-risk subset, a 90% reduction in the risk of end organ damage with early therapy. Number two, we did a study in Olmsted County, which is the mecca of smoldering myeloma and MGUS. And Giada Bianchi published this in Blood years ago. Only 17% of patients with MGUS were diagnosed with myeloma by the doctor suspecting, oh, the M spike is going up, and doing a workup. Even for patients in Mayo Clinic, Olmsted County, 83% were diagnosed with a disaster, like hospitalization, end organ damage. Unless you're planning to see the patient every day, you're not going to catch that end organ damage in time. So even follow-up, unless you're willing to start therapy when the M spike goes from 1.5 to 1.6, is not going to happen. That's my worry. And the number two reason why I don't recommend myeloma-like therapy right now is we need to really find out, is a preventive approach better or a full-blown myeloma approach better, not only for deciding what's right for the patient, but also for regulatory reasons. We have a clinical trial going on in the United States. For all of you who are in the US, please enroll patients in trials. Don't listen to my algorithms. Do the trials. The trials are the best way to manage the patients. This trial is comparing Lendex, what the Spanish showed improved survival, versus daratumumab Lendex, which is what we think a good myeloma-like therapy would be. And so the trial is asking the question, and if the clonal selection or harm by doublet is there, it will be seen in that trial. Let's do the trial. The trial is open. Let's not put patients outside the trial as much as possible unless you're really forced to. But try to do the trials, and the trial is asking the right question: is a myeloma-like therapy better for high-risk smoldering than a mild therapy?
Okay. I don't see any questions, which is a bit odd. No one has any questions about any of this?
Can I add to that too? And so Vincent, I couldn't agree more with that, what you said. The one thing I like in a trial is that the randomization is to treatment versus the intent to treat if you think they're progressing, not observation. Because we observe them for what? We observe them for an end organ problem. But instead of just observing them, we observe them to start therapy when we think there's a change that made us do that therapy. So they can get early therapy, but that's based on what we do in real practice. Yeah. And I think that would be more informative.
And I would really love to launch such a trial. We just, I'm involved in the daratumumab alone, single-agent smoldering myeloma randomized trial. I'm involved in the ECOG trial. I've done 2 other randomized trials in smoldering myeloma, so we are trying. But there are only so many trials we can do.
Right.
So I would encourage, if you really think you can actually manage smoldering by incremental, go ahead, run the randomized trial, and let's find out. Keeping in mind that until the trial comes, the data we have right now is that if the M spike goes up by 0.5 gram and the hemoglobin drops by 0.5 gram, that patient is at 90% risk of progression within 2 years. So those patients, you should be ready to treat. If you decide you're just going to watch them, but the M spike is going up and the hemoglobin is falling, don't wait for the full crab.
Believe?
Yeah, I think that the case that was presented by Vincent is a very difficult one because the patient was 51 and she had a translocation 414, and according to the updated risk stratification for smoldering myeloma, the new International Myeloma Working Group classification, we have these 3 criteria that are very important. The M spike of more than 20 grams per liter or 2 grams per deciliter, the 2-20-20 classification, 20% of plasma cells, and the free light chain ratio of more than 20, above than 20. And then the specific patient have all these 3 criteria, plus 414 translocation. It means that if we are going back to the slide number 29, this slide is very, very important for the decision. the risk of progression to a symptomatic myeloma at 2 years was 60%. And the patient is 51. So, okay, why not treating this specific patient? She has a very high risk of progression, but how best to treat this patient? We have overall survival data with Lendex, and based on the study from the Spanish group, from Mariví Mateos, published twice, in fact, with a very long follow-up. The median follow-up for time to progression was not reached in the Lendex arm after 70 months of follow-up. It means that potentially we are going to delay progression, but can you imagine that the patient will receive Lendex during 7, 8, 9 years? I'm not sure that you will be able to tolerate 7 years of Lendex. To my opinion, that's not feasible. Or, on the opposite, you have the curative approach aimed at curing the patient based, for example, on the CESAR study or the ASCENT study with a very intensive treatment. I would favor, in fact, a very intensive treatment, but I would like to see the final results of Mariví and the study that is ongoing in the US, chaired by Shaji.
I think you bring up an important point about the limited duration of therapy, and I don't think we should just say don't treat because all the data shows patients are being treated continuously. I think looking back at Jesus' slides, I think the most important slide was the one who decides treatment. Is it you or is it the physician deciding or the patient decides? Because what we are really saying is now you have 2 trials with progression-free survival improvement, which if it was a drug or if you look at the transplant versus not transplant, with similar curves, we are willing to transplant the patient with myeloma with the same degree of PFS improvement without overall survival difference. So the question here is you have to show the data to the patient and say these are the pros and cons and partner with them to make the decision instead of saying, no, I don't believe this, I don't want you to be treated, or I believe this and you should be getting Lendex. And I think the second big question is, we don't know the answer to the question, as Vincent said. Should we be trying to prevent the progression the way the ECOG trial or the Mariví's trial was designed, or should we be treating them like myeloma? And I think that's where the clinical trials are being designed to ask the question, is it DRD better than RD? And I think the good thing about the ECOG trial is it is a limited duration of therapy and specifically gets to the question that you raised, Philippe. Can we stop therapy after some point in time?
So we're going to have to move on. The only final comment that I would make is that hopefully with molecular testing or immune testing, we will reach the point soon where we can tell if a patient has early myeloma or MGUS. And so there will be no more smoldering myeloma. So we won't need to have a lot of trials. I think that would be the simplest answer that we can achieve within the next 2, 3, 4 years, hopefully. All right, well, thank you for that. I'm sorry we didn't have questions, so please be thinking about questions that you can bring up for us. Let's move forward to our second case discussion and presentation, and evolution of upfront therapy for transplant ineligible patients. And so please welcome Shaji Kumar.
Good afternoon, everyone, and I would like to thank Brian for the opportunity to be here at this symposium today. One thing you might notice, always you see the transplant eligible talk before the transplant non-eligible talk. So this is not by purpose, but I think increasingly, it makes sense in the sense there's increasing convergence as to how we are treating patients with myeloma, irrespective of their transplant status. It's in no means a reflection of transplant being any less important in this disease. What I'm going to try and do over the next 10 minutes is to kind of walk you through how the treatment has evolved for patients who are considered ineligible for stem cell transplant who don't want to go to a stem cell transplant. Before that, let us go through the patient case first, and these are my disclosures. So now we have a 75-year-old male who presents with increasing back pain, and that was associated with radiculopathy. MRI or imaging studies shows multiple lytic lesions, clearly myeloma. Initial lab evaluation shows elevated total protein, slightly elevated creatinine, has a slightly decreased hemoglobin, normal calcium, and M spike of 3.2 gram per deciliter, G kappa, elevated kappa free light chain, and elevated beta 2 microglobulin, placing this patient at ISS stage 3. 60% plasma cells in the bone marrow with a FISH showing trisomies of 7, 11, 14, and with normal conventional cytogenetics. So which of the following therapies would be used for this patient as the initial treatment? Please go ahead and vote.
Want me to walk over there? Want me to walk and tell them?
Yeah, you could.
Okay. I'm just going to go tell them there's a mic off on in the audience.
Okay.
All right, so we have about a third of the group going for bortezomib, lenalidomide, dexamethasone, and we have about 1/5 going for daratumumab, lenalidomide, dexamethasone.
Over there is on.
All right,
You can hear him talking.
that's a good place to start off with.
Yes.
Let's move on to the, see if I can move past this slide here. Yeah, here are the recommendations from the group up here. As you can see here, looks like those two choices are reflected very well in this panel here. Now, so let's walk through why we have chosen, or the majority of us have chosen, the combinations that have been highlighted here. I think it's important to think about, again, what is the goal of treatment in patients with myeloma? Obviously, what we want to do is to try and get the tumor burden to the lowest possible level. And what has been important, obviously, is the diagnosis. And as we just talked about, the subtleties in terms of differences between who has smoldering myeloma that does not need therapy and active myeloma that needs treatment. And equally important is the risk stratification in patients with myeloma. We are not going to go much into the risk stratification at this point, but I just want to walk you through the overview of how we treat patients with myeloma. One of the questions that we have always asked is this patient eligible to go to a stem cell transplant, in which case these patients then get a limited duration of induction therapy, followed by a consolidation that is typically an autologous stem cell transplant, followed by maintenance therapy. And Dr. Morrow is going to walk you through the current approach for these patients. What I'm going to try and focus on are the patients who are considered to be transplant ineligible, where the typical approach is to start with a therapy and follow the same treatment for a period of time. But the important question is, who are these patients whom we call as transplant ineligible? And there are very different ways of defining it. Beauty lies in the eye of the beholder. But the primary question has always been age. And a lot of the randomized trials have been designed based on the age of the patients, and often the magic number has been 65. And there's no good rhyme or reason why it's not 60 or why it's not 70. But 65 is what has been used in the phase 3 trials. But we know from a variety of different studies that even older patients can go to stem cell transplant. There is an analysis from the CIBMTR that's going to be a poster at this, or a presentation at this meeting that I would encourage you to attend. There are other factors that are also important, things like the comorbidities. Are they able to undergo the stem cell transplant? Frailty is important. Access to healthcare often plays a role in who gets a transplant and who does not. And increasingly that you realize that patients walk into your office already having made up their mind whether they're going to have a transplant or not. So that the patient choice is important in making that decision. And the other thing that is changed over the past, especially over the past decade, as the type of treatments we use for newly diagnosed myeloma converges, the question of who is eligible for a stem cell transplant doesn't need to be made the moment they walk into the office. That's probably the last thing they want to hear from you. On top of everything is stem cell transplant. So we can easily ask that question after one cycle of treatment when they are feeling much better and some of the complications of the disease have been reversed with the initial treatment. Then the next question is, why is age an important factor in terms of deciding the course of therapy? The most important thing, I think, is comorbidities, because many of these patients have other comorbidities like hypertension, diabetes, which can be made worse by the treatments that we use in this disease. Renal insufficiency is common, leading us to having to dose modify, osteoporosis, which is not going to get better with dexamethasone, and the psychological issues, which certainly won't get better with dexamethasone. And there's obviously the frailty that is increasingly recognized as important, and we are trying to figure out how best can we assess it in a very simplistic fashion because it does have an impact on the treatment. Altered drug metabolism, limited social support and financial issues, and limited mobility and independence all play a role for these older patients. So let's take a look at where we started off from and see how this has evolved. So when we go back 20 years ago, the median overall survival for patients with myeloma, as you can see, is about 2.5 years with melphalan prednisone or comparable regimens. And we have tried over the years to ask 3 important questions. One, can we make melphalan prednisone better? Can we actually get rid of melphalan, or do we need it? And finally, how long should we treat these older patients with myeloma? So in order to answer the first question, there has been a series of phase 3 trials that have been done that have initially tried adding thalidomide to melphalan and prednisone. Some of them showed PFS improvement, a couple of them with overall survival improvement. We have tried adding bortezomib to melphalan and prednisone. The VISTA trial showed that adding bortezomib definitely improves the overall survival in these patients, with all different subgroups of patients deriving benefit. But I think where we are today is, how can we incorporate even the newer agents into this paradigm? So all of you are familiar with the trial results from Alcyon, which compared daratumumab with VMP versus VMP, and demonstrated that these patients have a much better progression-free survival by addition of daratumumab to the VMP regimen. And the response depth was much better when you added daratumumab to bortezomib, melphalan, prednisone, showing that this is an effective combination. And in this meeting, you will also hear from Dr. Mateos the updated results showing that there is an overall survival improvement for addition of daratumumab to bortezomib, melphalan, prednisone. So clearly, this is a regimen that's already been approved in different parts of the world, and certainly something that you can use. And many of you in the audience probably have used this. But the important question for us is, now that patients with myeloma are living 10 plus years, do we really need to use an alkylating agent like melphalan right in the beginning, with some potential consequences in the long run, both in terms of bone marrow reserve as well as second malignancies? So there has been an increasing push to see, can we develop regimens that are melphalan free? One of the original trials, the first trial, looked at using lenalidomide dexamethasone either for 18 months or continuously, and compared that to melphalan, prednisone, and thalidomide, and showed that Lendex used continuously had a better PFS and had a better overall survival compared to melphalan, prednisone, thalidomide combination, initially showing that Lendex is a reasonable approach for these patients. Subsequently, Dr. Dury did a phase 3 trial in SWOG that looked at the combination of bortezomib, lenalidomide, dexamethasone, comparing that to Lendex, again showing that there's not only a PFS improvement, but actually an overall survival improvement, suggesting that we don't necessarily need to limit ourselves to a doublet. We can actually use a triplet even in these older patients. But we all know who treat myeloma patients that it can be challenging at times to give them the standard VRD regimen. And there's this VRD light regimen that was developed by the folks at MGH, which looked at a more lighter version of RVD, which again gave a very comparable response rate and depth of response, suggesting that again we can use the same 3 drugs but with some modifications. And more recently, there's data from the MAIA trial that looked at daratumumab combined with lenalidomide dexamethasone. This essentially randomized patients to continuous therapy with either the doublet or triplet. And this trial clearly showed that there was a significant improvement in the progression-free survival compared to just using the doublet with the use of daratumumab. And this again correlated with a very deep response, including the MRD negativity rate in these patients. So clearly we have data showing that there are 2 triplets that have shown benefit in this patient subgroup. There will be updated data from the MAIA trial that will also be presented at this meeting. Now the next question is, how long should patients remain on treatment? Many of these phase 3 trials continued therapy until progression, and we don't have a very good answer yet. But this is a meta-analysis that was done by Dr. Palumbo based on a bunch of different European trials, suggesting that maybe continuous therapy did improve the overall survival compared to a fixed duration therapy. But I would say that the answer is still unknown, and there is a phase 3 trial in ECOG where we randomized non-transplant patients to 2 years of LEN maintenance versus continued till progression LEN maintenance, and hopefully that trial will give us some answer to that particular question. But what is very clear is that the shorter duration of dexamethasone is better. There is this trial that was phase 3 trial that was presented by the Italian group at the last ASH meeting, where they reduced the dose of lenalidomide and discontinued the dex in a planned fashion after 9 cycles of therapy, and in showing that less is better, and the patients who actually had the dex dropped and the lenalidomide dose dropped actually did much better in terms of event-free survival. So I think there's still an ongoing debate about the duration of therapy. It certainly improves PFS, but I think there's mixed effect on the overall survival. There's obviously the question of increased toxicity, both financial as well as other side effects of the drug, and the quality of life. So I want to conclude by saying that in 2020, we don't necessarily need a melphalan-based combination for the initial therapy of patients with myeloma, even those who are not considered eligible for stem cell transplant. I think that the 2 triplets, I think, which should be the standard of care for today would be bortezomib, lenalidomide, dexamethasone, or daratumumab, lenalidomide, dexamethasone, and then there's increasingly the adoption of the dara lendex into this practice. However, until we have more mature data from the dara combinations, I still would prefer to use a proteasome inhibitor-based combination in patients with cytogenetic high risk. And in those patients who are really much older and frail, the doublet still has value, and again reinforced by the control arm in the Maya trial, again showing a 32-month PFS for the lendex regimen. And I think for right now, we can continue the treatment till progression to the extent it's tolerated until we have more definitive data from phase 3 trials. But I think it's most important for these older patients to start low and then go up on the doses as tolerated rather than trying to treat them with the full dose of all the medications. And I think one thing is very important is to discontinue the dexamethasone as soon as you can and very carefully monitor these patients for toxicity related to therapy. So I'll stop there and thank you for your attention. And I guess we'll go back to our patient case here. Let's see if we have changed anyone's mind. Yes. This is again the patient case example. We have the 75-year-old gentleman with ISS stage 3 disease. Let's see what we're going to use for treating this patient. Here's some soothing music here. So. All right. We've gotten the choices narrowed here so to 2 regimens. So 82% of you will use either one of the 2. All right, we converted all the doublet treaters to triplets. Thank you.
All right. So thank you for that. So far, VRD is winning the day, I think. It's actually interesting to ask Shaji, you made one point, which was that you recommended VRD for the high-risk patients versus DRD, and certainly there are data to indicate that would be a good choice. How about KRD for an elderly patient? Do you want to comment on that?
Certainly. I think for the high-risk patients, in the transplant-eligible patient population, especially, I think if you look at the MSMART algorithm, we have recommended using KRD combination for the high-risk patients. The basic assumption there is in patients with high-risk disease, the existing therapies haven't really improved their outcomes. So can we hazard a guess from phase 2 trial data that a particular regimen may be better than what we use today and potentially use them with the question of risk versus benefit? And obviously what we really need is phase 3 trial data, and we will get that from the ECOG trial that looked at the KRD versus VRD, which hopefully we will hear soon. But in the older patient population, I am a bit more uncomfortable taking that leap of faith because there is definitely the toxicity aspect which might be more difficult for the older patients to handle. So I think in the older patients, I feel safer using something where we have lots more data, both in terms of the VRD or the VRD light and the outcomes that have already been shown in those patients. So I'm willing to hazard, less willing to hazard a guess in the older patients and the younger patients.
Okay. Raise your hand if you have a question, and a microphone will be brought to you, okay? Philippe needs to say something first, and then we'll take our first question in the middle here, I think. So, Philippe, you want to go ahead first?
Yes, in the meantime, this case was not that simple, to my opinion. 75 years of age, and Shaji did not mention anything regarding performance status and regarding comorbidities. So that's very difficult for me to propose VRD without knowing anything regarding frailty, comorbidities, and so on. We know that potentially VRD may be toxic in a frail patient, and you mentioned very clearly this in your talk, Shashi, thank you for this. And so I was unsure, so that's why my choice was Lendex bracket bortezomib, because Lendex is very feasible for this elderly patient with some comorbidities or frail patients. Dara-Lendex, more than 20% of the audience wanted to use Dara-Lendex. This is not yet approved in Europe, at least. We cannot use Dara-Lendex yet. And we know that this combination is potentially very interesting, very safe, and into Maya, more than 40% of the patients were above 75. So potentially a good option, but for the future, not yet available in many, many countries. So I'm really surprised. What we want to use or what we can use is always very different.
Okay, so we'll take a question. Number one here, I guess, in the middle. Please go ahead.
Thank you. In my opinion, we have two parts of the treatment of patients with multiple myeloma. The initial part, where the goal is to kill as many myeloma cells as possible, as fast as possible. And the following part of the treatment is to reprogram, the goal is to reprogram the patient's immune system so we can obtain control, long-term control of the disease. And this has important implications for how we look at the response, the speed of the response, because in the initial part, we want a rapid drop of the M protein as a sign of effective killing of the myeloma cells. And in the later part of the treatment, we can be completely satisfied if the M protein is dropping slowly, even over a year or more, coming down, because this is a different part of the treatment.
Right, so those are two options. Actually, Vincent is the one who has focused on these two strategies to slowly control versus decisive therapy. You want to comment on that?
No, that's very eloquently stated. I don't want to add anything because you just put it down very, very clearly.
Yeah. Okay.
Questions?
So while waiting for that, okay, good.
I have another one.
All right. Yeah, please go ahead.
In your practice, what was the most long time that you use dexamethasone in elderly, fragile patients?
So I try to take off the dexamethasone as soon as I can. Once I start seeing the patients responding, I progressively dose reduce them, and once they get a deep response, usually by anywhere between 6 to 8 months, I try to completely discontinue the dexamethasone. The older the patient, the sooner, and sooner I see the response, the sooner I try to take them off.
Okay.
Number two?
If age is really just a proxy for comorbidities, and we can assess comorbidities, why even look at age?
So it's not only comorbidities,
Okay.
right? I think there's obviously other things that go with that. So there's two parts to it. One is what you assess at the time of diagnosis in terms of comorbidities. And the second thing we all see in the practice is you can have a 75 and a 65-year-old, you give the same therapy. The 75-year-old is certainly going to have more toxicity. So I think the question is not what they can take today, but what they can tolerate until tomorrow. So I think that also needs to be taken into account. I think that's one of the reasons why I think some people look very good, a 75-year-old, but you can make them look very bad by giving something that is intense. So I think we really need to factor that in as well.
Maybe I can ask the panel, do we have any sense that the biology of the myeloma is different by age, that it has a different pattern of response to therapy, that we should be looking at that?
Well, I think in terms of the high-risk group, so the older you get, actually, the lower the incidence of the high-risk disease. So that's actually a better thing.
Yeah.
I do think there's still the worry about high-risk disease in elderly that you still need to give them a proteasome inhibitor. But thankfully, it's on the lower side. And I would agree with what was said earlier about looking at long-term immune function. And it probably is lenalidomide and potentially a CD38 antibody that enhances that immune effect over the long period of time.
Okay. Other questions?
Any other questions? Okay.
Any other comments?
I think I just wanted to highlight again what
you
Philippe
wanna
said
start?
about the performance status. I think, we all talk about adapting therapy, but it's remember that these frailty assessments and the comorbidity assessments are a dynamic thing. They change. So just because the patient was considered frail when you saw them first and put them on a doublet, and if they come back at the end of the first cycle feeling a lot better, please do consider changing that into a triplet.
Yeah, Vincent, yeah?
Well, I think one thing that didn't come up, and I think it's important to consider, is that clearly we have two triplet regimens that are really good for early control of myeloma, that is bortezomib, Lendex, and daratumumab, Lendex. But one is far more expensive. So I think cost absolutely has to be considered when you're making the call in terms of what is the best regimen for your patient. Please talk to your patients about affordability and choose a regimen that you think would be something that they can afford. There is no point in prescribing a regimen that is not affordable. And the second thing to keep in mind is you cannot compare one trial versus the other, so you cannot compare the SWOG trial to the MAIA trial. The SWOG trial used a triplet for 9 months, and then after that it was just lenalidomide dex. Whereas if you choose daratumumab Lendex and you want to use it like the MAIA trial, then you're talking 4 or 5 years of a triplet and 4 or 5 years of that extra cost. So keep those two things in mind. It's not just as simple as just, one can be mixed up with the other.
Yeah, really important practical points there. Okay, well, thank you. I think we can move forward now. So the next case discussion is upfront therapy for those who are eligible for transplant and also consideration of consolidation and what maintenance should be used. And so please welcome Philippe Moreau.
So good afternoon. And we are going to discuss this case, 63-year-old male with symptomatic myeloma with diffuse bone lesions, normal renal function, low beta-2-mic level, LDH below normal, and then the patient is diagnosed with a symptomatic myeloma, ISS1, revised ISS1. So what is your choice? Are you proposing VCD, stem cell transplantation, LEN maintenance until progression, VRD from 4 to 6 cycles, single stem cell transplantation, LEN maintenance until PD, VRD times 8, LEN maintenance and delayed stem cell transplantation. Patient is at a good risk. KRD times 12, LEN maintenance and delayed stem cell transplantation at the time of the relapse, or a more aggressive treatment, VTD DARA times 4, stem cell transplantation, VTD DARA consolidation, LEN maintenance, or VRD DARA, single stem cell transplantation, VRD DARA times 2, consolidation, LEN DARA maintenance 2 years, or you don't know, you're not sure at all about your optimal treatment. So please vote.
So a lot of options.
So choice number 2, VRD, from 4 to 6 cycles, single stem cell transplantation, LEN maintenance until PD. Quite interesting. So what is the opinion of the expert panel, in fact? Well, that's very, very similar. So this symposium is changing. In fact, we were arguing and fighting a lot in the future. Now there is a consensus, in fact. VRD, stem cell transplantation, LEN maintenance. So let's discuss, in fact, what are the current European guidelines we are proposing, when patients are eligible for stem cell transplantation, less than 70 years, fit patients, we are proposing a triplet induction, VTD, VCD or VRD, single stem cell transplantation and LEN maintenance. Why? We are never proposing in Europe delayed stem cell transplantation. This is based on the IFM study, VRD plus stem cell transplantation and LEN maintenance in the two arms of the study, comparing stem cell versus no stem cell transplantation up front. And you know that the progression-free survival in the transplant arm is highly improved, 50 months in median versus 36. And into the study, very interestingly, we looked at flow cytometry, 7-color flow, to assess minimal residual disease, MRD. The threshold was 10 to the minus 4. And when you are reaching MRD negativity, the overall survival is improved as compared with MRD positive patients. So definitely MRD negativity could be an endpoint of our future trials. So why VTD or VCD or VRD? VRD was recently tested into the Spanish study, 6 cycles up front before stem cell transplantation. And our colleagues reported this analysis very recently, 2 months ago in Blood. And you see that after 4 cycles, the VGPR rate or better is 63%, increased up to 70% after 6 cycles. So the benefit is not that important. Nevertheless, there is an increased response rate. Very often we are asking, should we use 4 or 6? We don't have any randomized study comparing 4 versus 6, but here you see that when feasible, potentially, it could be interesting to increase the number of cycles before stem cell transplantation. After patients did receive a single stem cell transplantation, 2 additional cycles of VRD, and you see that the response rate is deepening over time. That's quite logical with the addition of high-dose melphalan and 2 cycles of VRD consolidation. The same group used VTD 6 cycles in the past and published this experience in 2012. And when you are comparing the 2 consecutive analyses, VTD or VRD times 6, you see that the toxicity is totally different, in fact, and especially in terms of peripheral neuropathy. With VRD, when you are switching from thalidomide to lenalidomide, you are dramatically reducing the toxicity of this regimen. The same group looked at this integrated analysis of VTD versus VRD. You have VRD results, 6 cycles in blue, VTD, 6 cycles in red, and you see definitely that VRD is potentially more effective, and this translates into a better progression-free survival with VRD and stem cell transplantation as compared with VTD and stem cell transplantation. So this paper is currently submitted for publication. They also looked systematically at MRD negativity with the Euroflow technique, 2 tubes, 8 color, the threshold 10 to the minus 6 for them in their hand. And you can see that after induction, after 6 cycles, 28% of the patients are reaching MRD negativity. And this is a very high rate, 10 to the minus 6. And this rate is increasing after stem cell transplantation and also after consolidation and before maintenance. And recently, Bruno Paiva published a few days ago the MRD assessment into this study, VRD, stem cell transplantation, VRD, 2 cycles of consolidation and maintenance. And when you are looking at PFS before maintenance, for those patients reaching MRD negativity, the PFS is highly improved. But also, and that's very important, overall survival is highly improved when you are looking at the hazard ratio less than 0.3 in favor of the MRD negative group of patients before maintenance. So definitely MRD should be, to my opinion, an endpoint for future trials. Can we improve on VRD? We have KRD available and switching from bortezomib to carfilzomib. This is tested in the Forte study, a prospective randomized trial comparing KRD versus Carfil Cyclodex, KCD, and we know that with 4 cycles only after induction before stem cell transplantation, 4 cycles of KRD, the VGPR rate is at least 73%. That's 66% with 6 cycles of VRD into the Spanish experience. So potentially KRD is better than VRD, and Shaji Kumar is the PI of a very important study in the US comparing VRD prospectively to KRD. So definitely we will know if KRD is better than VRD. Another way of improving the induction part is to use a monoclonal antibody, and we tested in the randomized fashion VTD versus VTD plus daratumumab, both before but also after stem cell transplantation. And this Cassiope study showed that the DARA-VTD, the quadruplet combination, was feasible. 90% of the patients were able to undergo stem cell transplantation in the 2 arms of the study, and the response were also increased with the addition of DARA on top of VTD. And this also improved over time after induction, after stem cell transplantation, and after the 2 cycles of consolidation. And at the end of the day, before maintenance into this study, the CR rate was highly improved with DARA. The stringent CR was also improved. We looked systematically at MRD negativity, 10 to the minus 5, with flow cytometry. For all patients, more than 1,000 patients were tested. And you see that before maintenance, in the DARA arm of the study, 64% of the patients did reach MRD negativity versus 44% in the arm without daratumumab. So definitely a very high MRD negativity rate when using a quadruplet combination, including a monoclonal antibody and stem cell transplantation. This quality of response translated into a better progression-free survival. You see here the final analysis of part 1 of the study before maintenance with DARA, without DARA, the hazard ratio is 0.47. And we already have a trend for a better overall survival as well, although the follow-up is rather short, and this is not the final analysis of overall survival. You see the hazard ratio of 0.4. But definitely look at the overall survival rate, the 20-month OS rate in the DARA arm of the study. 97% of the patients on an intent-to-treat basis were alive. So unprecedented overall survival results with a quadruplet combination plus stem cell transplantation. This study, the Perseus study, is ongoing in Europe. This is the prospective comparison of VRD, and you are all of you, or the majority of you, considering that VRD is the best option prior to stem cell transplantation, with or without daratumumab, before and after stem cell transplantation. And interestingly, the study is also looking at LEN maintenance or LEN plus DARA during a 2-year period of time. So very interesting study, and the secondary endpoint is MRD negativity. What about tandem stem cell transplantation? We had this meta-analysis of single versus tandem stem cell transplantation in phase 3 trials that were run in Europe quite a long time ago. And Michele Cavo last year, during this meeting, published the update analysis with a very long follow-up, up to 10 years. And you see that tandem is improving overall survival versus single stem cell transplantation after bortezomib-based induction, and this is especially true for high-risk disease. And some of us in the room are considering that when a patient is harboring 17p deletion, for example, or 414 translocation, tandem is a good option. But this is here a huge debate. Should we use tandem? Should we use consolidation after stem cell transplantation? And the STAMINA study run in the US was reported early this year in the GCO, And the study design is very interesting. After a single stem cell transplantation, patients were randomized to receive no consolidation and maintenance until progression, or VRD times 4, consolidation based on novel agents, and maintenance, or a second high-dose treatment, a tandem stem cell transplantation, then followed by LEN maintenance. And a very high number of patients were randomized, 750 patients, and disappointingly, I would say, no difference in terms of progression-free survival when comparing the three arms of the study, and no difference at all for overall survival as well. So the conclusion of the authors from the US was that we don't need any consolidation after a single stem cell transplantation, and we should proceed immediately to maintenance. So in Europe, we are favoring consolidation. In the US, consolidation is not used. But all of us are considering that patients should receive a maintenance. LEN is standard of care, approved and reimbursed in many countries based on a meta-analysis of LEN versus no LEN or versus placebo. 1,200 patients were randomized, and you see here the overall survival benefit with lenalidomide. The benefit is almost 2 years, so that's quite an important discovery for the patients. This is the Tourmaline 3 study comparing ixazomib, an oral proteasome inhibitor, versus placebo, and the progression-free survival from the start of maintenance after a single stem cell transplantation is in favor of ixazomib, but you see that the PFS benefit is not that important, 5 months only, and we don't have any overall survival data. We need a longer follow-up. So ixazomib could be of interest. LEN is definitely of interest. So why not combining these two agents, IXA plus LEN? And this is what currently the Spanish group is doing in a randomized fashion after stem cell transplantation. Our colleagues are looking at LEN versus LEN plus ixazomib, and potentially the combination of a PI and an IMiD with a synergistic activity will show an improvement in the duration of the response. We are also looking into Cassiope at DARA maintenance after consolidation versus no maintenance, and the landscape potentially will change in the future. And what are the guidelines going to show? For example, in 2020, we are currently updating the guidelines, and this is a question mark. That's not the final paper that will be proposed next year. For sure, we are going to propose more and more a quadruplet induction with a CD38 antibody. KRD potentially can become a good option, and we will have the results of VRD versus KRD. The tandem stem cell transplantation for high-risk disease, this is a question mark. And the maintenance part also will change in the future, LEN as a standard of care, but potentially LEN plus IXA or LEN plus a CD38 antibody. But what is very important is to look at MRD negativity, and I mentioned this very important endpoint for the future. Is it possible to anticipate the outcome of the patients after induction based on MRD assessment? This is some data from the Cassiope study, VTD, DARA, and stem cell transplantation. And we looked at MRD negativity systematically after induction and before stem cell transplantation. And we showed that not only DARA is important and is a very important, the DARA arm of the study is associated with a better progression-free survival, but also MRD negativity after 4 cycles of induction is a predictor for progression-free survival. So you can anticipate if your patient is becoming MRD negative after induction, the outcome will be very good. Well, this deserves some music for sure. So this is the landmark. Should I stay or should I go? Or should I stay or should I go? So this is the results of the landmark analysis post-induction according to MRD status. And you see that those patients reaching MRD negativity after induction and receiving a quadruplet induction are enjoying the best progression-free survival. So the last picture is the future French study, the IFM study. What are we going to do, in fact? We are going to use a quadruplet induction and assess MRD with NGS with a threshold of 10 to the minus 5. And when patients will reach MRD negativity, we can anticipate that the outcome will be favorable. And we are going to randomize no stem cell transplantation versus stem cell transplantation up front, with a consolidation based on a quadruplet alone or quadruplet plus high-dose treatment, with a fixed duration of maintenance. On the opposite, for those patients MRD positive, we are going to propose stem cell transplantation and a consolidation or a tandem stem cell transplantation based on the poor outcome suggested by the positivity of MRD. And I thank you for your very kind attention. So let's go back to the patient case, 63, symptomatic myeloma, ISS1, revised ISS1. You can vote looking at the different choices. We had 50% of the audience favoring VRD times 6. Is it going to change? Definitely we have an increased DARA quadruplet use with VTD DARA or VRD DARA. And well, this is the future, but that's very interesting. Thank you.
Okay, so thank you so much, Philippe, for that. So very slight shift there toward the future with the added benefit of DARA. So raise your hand if you have questions, but any comments or thoughts from our panel about this? It seems that so far we have VRD, you just have one recommendation so far from each session.
So Luciano Costa has an abstract that he's going to present at this ASH, which is daratumumab plus KRD. And they do a adaptive design, and they're looking at MRD as an endpoint. And when a patient achieves MRD negativity for 2 subsequent values, then the person stops therapy. So to get to Vincent's point, if we treat them very aggressive up front with a quadruplet, it's got to be with something, I think, some benefit at the end, that hopefully that we can stop early and actually give patients the benefit of being off therapy. So I do think we have to, going forward, we have to use MRD as our way to tease back some of the medications.
Right, a key point for full use of a four-drug regimen. Yeah, we have a question here, number 1.
Number 2.
Oh, number 2, okay, number 2 is fine.
Hello, Professor Moreau, you have chosen a patient with translocation level 14, a subgroup when we have a targeted treatment, and venetoclax we know can work very well in the relapse setting in this subgroup. Do you think it's time to consider its use in the upfront setting as well?
Well, that's a very interesting question. Right now, we have some data with venetoclax in combination with bortezomib and dex in the phase 2 study that is already published with very good results. We know that venetoclax is able to target not only 11-14 but also BCL2 high patients. But we need randomized trials. I guess that the Bellini study is ongoing. We have other trials looking at Pomdex versus Pomdex, venetoclax in 11-14 in relapse patients. Currently, that's too early to move to frontline treatment, although I'm strongly believing that it could be interesting, but we need some data that we don't have yet. But your question is a very good one, for sure.
Okay.
Ashley, number 6.
Hi, I'm Phil Imus. I think the IFM 2020 is a really important study to do. But in the absence of that data, right now, if you have a patient who achieves MRD negativity after induction, are you still recommending high-dose melphalan, given that their outcomes should be excellent, whether they get that therapy or not?
Okay, good question. What do you think?
Well, that's a very good question. You know, during this meeting, we are going to hear about KRD DARA without stem cell transplantation frontline. The paper will be presented by Dr. Landgren on Monday morning, and is claiming that we can reach 80% of MRD negativity with KRD DARA alone, in fact, and without stem cell transplantation in young patients. Okay, this is a fact. We can go in very high rate of MRD negativity, but also one way to increase the MRD negativity rate and the quality of the response is to use high-dose melphalan. So definitely, I think that we need a randomized study, so that's why the IFM will run this study.
I think it's also important to remember that the patient who is MRD negative before transplant, who did well in those phase 3 trials, got a transplant. So we don't know how they would have done if they didn't get a transplant. So I think it's premature to jump into that conclusion at this point without the data from phase 3 trials.
All right. Number one right at the front here, Jean-Luc.
It's a question from Nantes to Nantes.
Okay.
No, it's mostly a comment. Don't you see it about consolidation? Don't you think that the interest of consolidation is quite dependent on the quality of the induction treatment, which could reconciliate the US and European results? Because when there is a benefit of consolidation, is usually because the induction has been short. And when we have a long induction with 6 courses of a good triplet or even more quadruplet, don't you think that at least for standard risk patient, consolidation would be useless?
Well, I agree with your proposal. I would like to see a study comparing 6 cycles stem cell transplantation with or without consolidation, but we will never have such results. But I agree with your proposal. When the induction is a very good and long with the quadruplet, potentially we don't need any consolidation.
Should we be aiming for Philippe? Should we be aiming for 6 cycles?
Well, this is the Spanish data are quite interesting with 6 VRD. We can. That's good to do 6 cycles, to my opinion, when feasible, when not too toxic, and the patient will be able to proceed to stem cell transplantation. And when looking at the feasibility of 6 plus stem cell transplantation, that's highly feasible. 90% of the patients are able to proceed to stem cell transplantation.
So for the 6 cycles, they had an innovation to use the 4-week schedule with 2 weeks of Velcade. Yeah. Is this something important?
We have different VRD proposals, 21 cycles, 21-day cycles, 28-day cycles. That's another point, in fact. And when you are comparing 4 cycles of KRD, 28 days, versus 6 cycles, 21 days. In fact, those intensity of lenalidomide and the dexamethasone is roughly similar. So we have to be careful regarding the number of cycles. That's also the number of months and the dose intensity that matters probably. So that's not that simple.
For IMW, that was one of the most common abstract submissions, is the comparison of 3-week versus 4-week RVD. And honestly, there was probably 14 abstracts. There was not a difference, didn't matter what the schedule was, there wasn't a difference in terms of the overall response rate. And really the CRs or VGPRs, it's all about the same. So I don't think there's much difference in terms of the that.
Okay, so we have another question over here, number 2.
In order to use MRD in standard clinical practice, we need a standard definition and a standard method. So I'm wondering what your opinions are on the state of things in terms of standardization of MRD.
First of all, in Europe, we are not using...
That's why I was asking this question earlier.
We are not using MRD outside clinical trials. NGS is quite standardized. Now, with flow, we also have this Euroflow technique that is well validated, 2 tubes, 8 colors. we can reach a threshold of 10 to the minus 5 quite easily. But we have some discrepancies, and for example, Dr. Landgren is showing one tube, 10 colors with flow cytometry. We need to be reproducible. That's very, very important. But Vincent can comment on MRD based on the I-square team assessment, that because we need to have MRD validated by the authorities as an endpoint, and there is a common effort from the companies and also from the cooperative groups to incorporate MRD in the routine practice. So maybe you want to comment, Vincent?
Well, you know, the subject of MRD you have to look at in terms of what is the purpose you're doing the test. So if you simply want to find out prognosis, is the patient going to do well or not? Just that. You could use any method. You could use flow, you could use sequencing, you could use -5, -6, and you will know based on positive, negative, what the likely outcome is going to be. If your goal is, I'm going to use the result to change the therapy, either stop therapy because they're negative or add therapy because they're positive, then I think we have to be very clear that just prognostic information is not enough. We need randomized trials to show that acting on that MRD result is going to change the outcome. Those trials are ongoing, and those trials need to be done. You know, take MRD, give a finite duration of therapy, do the MRD test. If they're positive, continue the same treatment versus adding something. Or if they're MRD negative, stopping the therapy. Those can only be answered by randomized trials. And then we have the purpose which the I-square team is trying to answer, which is it's becoming increasingly harder to get drugs approved waiting for overall survival results or even PFS. So can we use MRD as a surrogate endpoint instead? And that is what the I-square team is working on, to try and see if we can use MRD negative rates as a surrogate endpoint instead of overall survival. And then finally, it is the sustainability of the MRD negative and whether that will be a marker for cure. And what level of depth of MRD negative sustained for what period of time is reflective of what proportion of patients were cured. That's a separate question. So I think just jumbling these four things into MRD as a thing might be confusing, but you have to just go specifically what is the purpose, and then the test depends on that.
I think going back to a specific question, there exists a standard definition. The IMWG defines it as 1 in 10 to the power of 5 as the sensitivity for defining MRD today. Right. And we have specified that it can be either the next generation sequencing or the Euroflow methodology. Any methodology that is being validated to demonstrate the ability to get that sensitivity. I think going forward, we have to use that for all these randomized trials to prove the point. And the definitions will change over time as treatments get better.
Absolutely. Okay, I think that...
No.
One more question, okay?
From the
All
back.
right. Okay, a last question?
Yeah.
Go ahead.
Hi, this is Dr. Vishnu. So it's really encouraging to see the better results from quadruplets. Can you comment on the toxicity profile of quadruplets versus triplets, and also the patient's quality of life when using the quadruplets? Was there any significant difference, or you didn't see much difference in the toxicity profile and the quality of life?
Well, that's a very good question, very important one. When looking at Cassiope, VTD versus VTD DARA, in fact, the feasibility of stem cell transplantation was identical in the two arms. We have a higher rate of infection, but not severe infections. During this meeting, we are going to hear Dr. Voris on Monday morning presenting the Griffin study, a phase 2 study comparing VRD stem cell transplantation versus VRD DARA stem cell transplantation. And there is not a significant increase in the toxicity with the addition of DARA. On top of this, we can anticipate that in the near future we will have DARA sub-Q that is very well tolerated as well and very convenient also for the patient. So I guess that this quadruplet is really adding, and the ratio between efficacy and toxicity is in favor of the efficacy with a low toxicity rate.
Okay, and then I think, Vincent, you had a comment?
Yeah, I have two comments on an earlier question. The one was raised by Jean-Luc, and one was the gentleman who asked about the MRD negative patient. I want to comment on it mainly because when we come to the algorithms, I don't want it to be not covered. Number one, the consolidation question. I don't do consolidation, and it looks like 50% of you don't do consolidation. That's why it's VRD transplant maintenance. That's the 50% vote. And I don't do consolidation because there is a randomized trial, the CTN trial, which looked at induction followed by a single transplant and Len maintenance versus induction, transplant, consolidation, and then maintenance, and then induction, double transplant, and then Len maintenance. That's the only trial that isolated consolidation. Patients all got induction, transplant, maintenance. One arm got consolidation, one arm didn't. And it showed absolutely no benefit to consolidation. It just adds another $300,000 or $200,000 extra of cost and toxicity when the patients just had a transplant. And so with good quality induction, I absolutely do not do a consolidation. That's just my personal view, because there's no data supporting its added value to maintenance in an isolated randomized trial. Number two, as far as the MRD negative patient who is asking you, should I absolutely need a transplant? I think many, many physicians have come to me for opinion on that question when they get myeloma. And they really don't want to do the transplant because they want to continue their life as is. I just looked at I look at the randomized controlled trial data and ask the question, is there any randomized trial where if the patient just collected stem cells and opted for a delayed transplant, that they would actually survive less? There isn't. Maybe there's one, but there are 4 trials which say that there isn't any difference. Not only that, if the patient is on top of it MRD negative and standard risk, then I think we need to do the same thing we did for the smoldering myeloma patient. Tell the patient these are the options, and this is all the data we have. PFS may be longer, MRD negative rate may be higher, but you're already MRD negative, so I cannot make it any more negative. So I will tell you this is the data we have and do a shared decision making. And certainly there are many patients, I would say about a third of the patients at Mayo who are standard risk will opt for collect and store, which is okay only if you can collect and store forever and you are definitely planning on doing the transplant at first relapse.
But I think the catch to that specific question is you're making that decision one way or other, irrespective of the MRD testing is done or not.
But if the MRD is negative, it's even more unlikely that the transplant will happen.
Now we are making the assumption that it's right because we don't have the data from randomized trials, just as you said. But I just want to get back to the point you made about the 6 cycles of BRD. And I think the point you made was that the depth of response went up from 63 to 73%, and that's why you prefer the 6 versus 4. But I'm not sure if there's data to say that an incremental depth of response prior to transplant actually translates to an overall survival improvement. Because the MRC trial clearly showed that if you give additional cycles of consolidation for patients or additional cycles of induction before transplant for the suboptimal responders, didn't really change the overall survival, only changed the PFS.
That's true, but...
Okay, well, I think we're going to have to move on. But it's interesting that we don't have much discussion about the choice of drugs, but 1 transplant or 2 transplants, quite a lot of discussion. Okay. We'll go ahead now with what is basically the final session is combined discussion on 2 aspects of relapsed refractory disease. And so Vincent Rajkumar and Tom Morton will cover this topic. One focusing on combinations with approved drugs and the other focusing more on the future directions with agents still in clinical trials. So first of all, I'll welcome Tom, who's circling behind me here. Please welcome Tom Morton.
Hello. So I'm going to introduce the case, and then Vincent and I are going to talk about. He's going to talk about early relapse, and I'll talk about when all else fails.
Yeah.
So in this case, it's a 72-year-old male, otherwise healthy, who presented with back pain and fatigue. He had compression fractures of L4 and L5. In terms of labs, he had a mild anemia, elevated total protein, an M protein of 4.2 grams, a kappa light chain of 1,200 milligrams per liter, and an elevated LDH. He had PET imaging that showed multiple hypermetabolic lesions, and then a bone marrow biopsy showing 75% kappa-restricted plasma cells in fish with 1Q gain in 414 translocation. So he was treated with RVD for 6 cycles and achieved a VGPR. And like we found out in our last discussion, he went to transplant, and his 3-month response was a stringent CR. So he was immunofix and SPEP negative with normal light chains and IHC negative on his bone marrow. But he did have an MRD test, and his MRD was positive. So he received continuous RVD maintenance vis-a-vis the Emory approach for 21 months until follow-up showed increasing light chains. He didn't have an M protein, he just had light chains. His kappa light chain was now 150 milligrams per liter, so it went from normal to 150, with a lambda of 5 milligrams per liter and a ratio of 30. But he remained asymptomatic. So let's vote. Okay, so in your current practice, which of the following treatment options would you choose? Observe, he's asymptomatic, you can follow the pace of disease. 2, switch to daratumumab lenalidomide dex, DRD, daratumumab pom dex, DPD, daratumumab bortezomib dex, DVD, daratumumab carfilzomib dex, DKD, or carfilzomib dex, KD, or carfilzomib pomalidomide dex, KPD, and finally ixazomib lenalidomide dex, or are you unsure? Let's vote. A lot of options. And survey says, okay, a wide splay with the majority of people saying to observe him, and you can follow the pace of his disease, and then a backup to that to do daratumumab pomalidomide index, and then a few for daratumumab lenalidomide dex, and a bunch of other daratumabs, including a daratumumab carfilzomib dex. So the majority of people actually chose a daratumumab-based regimen. All right, let's see what advisors showed. Okay, so across the board, most of us chose daratumumab pomalidomide dex. Most of us would switch because they have high-risk disease and had progression on therapy. And then Dr. Dury and Dr. San Miguel also thought carfilzomib, daratumumab, and dexamethasone would be a reasonable option. Okay, continued. So the patient was treated with daratumumab pomalidomide and dex, and after 2 cycles, he achieves a VGPR, immunofixation positive. He continued DPD with reduction in pomalidomide and dexamethasone due to side effects, and then at 9 months, he experienced increased light chain values. His kappa was now 50 milligrams per liter. His lambda was 2.5, ratio of 20, and he developed symptomatic femur pain. An MRI shows a large bone lesion with a soft tissue component. The PET showed no other lesions. So let's vote on this one. What to do? In your current practice, which of the following would you choose next? Radiation to the femur, focal rogue area, and then continue DPD. Switch to carfilzomib, PomDex, KPD. Switch to daratumumab carfilzomib dex. Switch to elotuzumab, pomalidomide and dex. Or go to selinexor or dexamethasone. Or how about a clinical trial with a BCMA-targeted agent? Are you unsure? Again, a lot of options. Okay, again, we got quite varied, but many of you, a third of you, would send them to a clinical trial targeting a BCMA antigen on the cell surface. I like that. We'll talk about that right after Dr. Rajkumar. And then about a fifth of the people had said, just do radiation and continue DPD. And then the next one was daratumumab, carfilzomib, and dexamethasone. Okay, so what did the experts say? So a bunch of people said clinical trial targeting BCMA. We have carfilzomib, pomalidomide, dexamethasone for a couple. And so there is no one answer for these questions, which makes myeloma actually quite interesting. All right, continued. The patient was treated with KPD. He achieved stable disease with stable serum-free light chain values for 4 cycles. Then a repeat PET shows 2 new lesions with no change in the light chains. Let's vote again. We're going quick. Okay, now, how about now? Selinexor and Dex. Next, bendamustine and Dex. Next, treat him with chemotherapy, hyper-CVAD or DPACE. He has very aggressive disease. And then a clinical trial targeting BCMA, or a clinical trial targeting a novel alkylating agent like melflufen, or a clinical trial targeting a new cereblon, E3 ligase, like CELMoD, like iberdomide, or other or unsure. Yeah. All right, so the majority of people said, let's go to BCMA. Okay, very good. That's excellent. And what did the experts say? Pretty much everybody said targeting BCMA, except for me, I said all the above. And we'll talk about that. Okay, with that, I'm going to invite Dr. Raj Kumar to come up and talk about the landscape in relapse refractory myeloma, which combinations to use and when. Thanks.
Well, I wish I was paying attention to these questions when they came to me to answer. So it looks like I answered them completely wrong. The first patient, I think I said Dara-Pomdex or something. Anyway, please don't do as I say, not as I do, or whatever. The main thing with relapse is that if you heard the arguments about should we use Dara-RD or KRD or Dara-VRD or Dara-KRD and so on, all those complications and choices are nothing compared to the choices we face in relapse, because there's so many more regimens and so many more factors you have to take into account when you want to pick a regimen. It's not just as simple as picking the best myeloma regimen as you would do in the newly diagnosed setting. So here is a small acronym that I use. It's TRAP, T-R-A-P, which is we need to consider the timing of the relapse. When is the relapse occurring? Is it 1 year after stopping therapy? Is it while the patient's on therapy? Is it several years the patient's been off therapy and now they are relapsing? And that's very critical in terms of what regimen you're going to choose. How did they respond to the previous treatment? So for example, if they had VRD for 1 year, did really well and then went off therapy for 4 years and now they're relapsing, you might just go back to the VRD again. So response to the prior therapy in terms of how did they respond, how did they tolerate it is the second factor you have to consider. How aggressive is the relapse? Is the relapse just a simple monoclonal protein rising, or is the patient relapsing with circulating plasma cells and extramedullary plasmacytomas or lytic lesions? And then what is the performance status of the patient? How much can they handle? Can they handle another transplant? Can they handle a quadruplet regimen or VDT-PACE? Everything has to be considered when you pick the regimen. So first I'll just go through the data that are out there for the randomized controlled trials for relapsed disease. There were 4 drugs that were approved using a Lendex backbone. So Lendex versus Lendex plus one of these drugs. Carfilzomib, ixazomib, daratumumab, elotuzumab. And I won't go through the data in detail, but it's pretty straightforward that all of these drugs are active. And if you compare them as a triplet versus Lendex alone, we found benefit. So carfilzomib Lendex was significantly better than Lendex in the Aspire trial. Ixazomib Lendex was better than Lendex in the Tourmaline trial. Elotuzumab Lendex was better than Lendex in the Eloquent trial, and daratumumab Lendex was better than Lendex in the Pollux trial. All these resulted in these 4 drugs getting approved because they showed beyond reasonable doubt that the drug is active in relapse disease. There were a couple of studies done with the bortezomib dex backbone. Daratumumab did 2 trials, so they had one with Dara bortezomib dex versus bortezomib dex, and then panabinostat. Same story here. The triplet was associated with better progression-free survival. Panabinostat, bortezomib dex versus bortezomib dex, and then Dara bortezomib dex versus bortezomib dex. These also resulted in these drugs getting approved and these regimens getting approved. What we know is that these are active drugs. It's actually a great strategy to get a drug approved because you're showing the control group is not placebo. The control group is getting therapy, and then you're showing that the new drug is adding value. The problem with these 6 trials right now for me is that these are 6 good regimens, but they have not been compared head to head. So we have all these trials of 2 versus 3, but not a single trial of 3 versus 3 to tell me which of these would be the best treatment for first relapse. And in the absence of such a trial, we have to really not compare across trials, but look at the hazard ratios and see if we can make some sense. And this is from a paper that Bob and I did years ago. And you can see that daratumumab-based regimens in general had almost like a 65 to 70%, 60 to 65% reduction in the risk of progression. Whereas the other regimens had more like a 25 to 30% reduction in the risk of progression. So to me, any of these triplets is great, and you'll have to choose them based on affordability and the trap factors that I mentioned. But if I had to choose and all factors were equal, then a DARA-based regimen probably is my preference. And that is why the algorithm here is if the patient is not refractory to lenalidomide, a DARA-Len-Dex is reasonable. If the patient is refractory to lenalidomide, DARA, bortezomib-dex, or DARA-POM-dex. All these 3 regimens are approved in the US for patients with relapsed disease. But you could choose any of these other regimens as well, and that you would not be wrong. I don't think a patient is going to live longer because you chose one ahead of the other. I think as long as you are giving the patient the opportunity to take each one of these in some rational manner in a successive, as they relapse each time, they should live just about the same length of time, and the only factors that will be our performance status, can they tolerate the regimens, and affordability. The problem also is that these 6 trials were mainly done with patients enrolled in Europe and other countries, not in the US. And in the US, right now for first relapse, we are encountering only patients who have already had lenalidomide, whereas these trials enroll patients who had not, by and large, seen lenalidomide. So we have to have a second generation of trials which looked at what are the outcomes in relapse disease for patients, or what are the regimens we can use for patients who are already exposed to lenalidomide for 3-4 years, for example. And here we have at least 5 trials that have come. Most of them are randomized trials, not all. And we have some really good data here on pomalidomide dexamethasone-based regimens. And you can see here ELO-POM-DEX versus POM-DEX. Significant improvement in progression-free survival. This was a surprising trial for me because the benefit of ELO with POM-DEX was much more than what it had with Len-Dex. Isatuximab POM-DEX versus POM-DEX, this study has been published in The Lancet. This is a monoclonal antibody against CD38, just like daratumumab. It's not yet approved. Hopefully it will get approved and compete with Dara on price maybe. But it seems to be as effective or equally effective in phase 2s. And in this phase 3 trial, it was superior to POM-DEX. Pomalidomide bortezomib-dex versus bortezomib-dex is another triplet that's been studied in Len-exposed patients in the Optimism trial and was found to be beneficial. You had a couple of phase 2s. One is daratumumab POM-DEX, a regimen we use commonly in the US, and carfilzomib POM-DEX, which we also use commonly in the US. How do we put this together? The problem is that these regimens are going to just keep increasing. You're going to have 20, 30 regimens that you could choose for second relapse, because if first relapse choice was a problem, second relapse is even more of a problem. Therefore, I think it's more important to just go into principles. And the principles are that you want to choose at least, if a patient's relapsing, you want to choose a triplet or better, maybe even a quadruplet. You want to have at least 2 new drugs compared to the regimen that they are previously relapsing on. So if it's VRD, you should go to Dara-POM-DEX. I should have gone to Dara-POM-DEX. I don't know why I put Dara-bortezomib-dex. I think that is a typo. I take the 5th. So you need at least 2 new drugs. And then you need to consider transplant in all the eligible patients for 2 reasons. As I told you, whether we like it or not, some patients do not want early transplant and they are storing stem cells for future. But we cannot forget that they have stored stem cells for future. So when they relapse, we have to always consider, is the patient transplant eligible? Do they have stem cells in reserve? Have they opted previously for a delayed transplant, and should I do that transplant now? Or if they had a really good response with the first transplant, maybe you do the transplant again the second time when they relapse. And then better still, clinical trials. A lot of these progress that we've seen would not have happened unless we've had these clinical trials. And there are a plethora of clinical trials for relapse disease in almost any country. So what are the algorithms for second or higher relapse? Really, it's very hard to tell, other than to say any of the first relapse options that the patients previously not tried would be reasonable, provided you follow the principles of using at least 2 new drugs. And then there are several additional options that you can use for each subsequent relapse. You may have to go back to the old regimens like VDT-PACE or anthracycline-containing regimens. Not forget melphalan and alkylators. For example, Cybor-D or a melphalan-based regimen, or melphalan itself given IV can give you a response in a number of patients. Selinexor has just been approved in the US, and there is an abstract here with Selinexor Pomdex, which seems to be quite active in relapse refractory disease. Bendamustine-based regimens, adding panabinostat to a PI or proteasome inhibitor, adding panabinostat might get you an extra response, or starting to consider quadruplet or even 5-drug regimens to control the disease as much as possible. And if we have all these drugs, we are going to have even more in the future. As you know, CAR-T's therapy is highly effective in myeloma, and hopefully we will have some approved soon. Belantamab, the anti-BCMA antibody from GSK, is active, and those results so far are very promising in phase 2. Hopefully that drug can get approved. The Amgen compounds 420701, you should be hearing about that very soon, the BiTEs. Isatuximab, iberdomide, venetoclax, melflufen, the list goes on. There are going to be a number of options. As these drugs come up, I think we will have better ways of controlling the disease, making myeloma more into a chronic disease. But we have to somehow follow certain principles to make sure we choose these drugs in rational sequence. So I will close here, and to discuss all these options that I showed on that slide, which I didn't go into in detail, I'm inviting Dr. Tom Martin, who will come and give you the scoop on that. Thank you. Thank you.
Thanks, Vincent. So I am going to describe the landscape in truly refractory myeloma, what we use when all else fails, and also talk a little bit about the drugs that I think are going to be available in the not-so-distant future. So now, we talked about this case, and there were, I think, some important parts about this case that we see commonly in our clinic. This is an older patient who's had 3 prior lines of therapy. He's had RVD and was refractory to RVD, double refractory. He had DPD for 9 months and then became refractory to Dara-POM, and then had KPD and became refractory to KPD. He is actually a penta-refractory patient. This patient has high-risk disease. This happens in our clinics all the time. And I would say that this patient has triple-class refractory disease. Rather than saying every agent is triple-class refractory disease, I think at the current time, that really is the unmet medical need for us. We need more drugs for this population. It also, this case shows the point that he had an M protein at start, but over time the M protein went away and had what was called light chain escape. We always have to follow the light chains, because it's often the light chain is going to be the measure of their disease activity. And then at the end, his light chains didn't even go up. And so some people actually become very oligosecretary. That is a tough patient, because often they don't qualify for a clinical trial. So I put this panel together. On the left, or in blue, are what we have available for us for such a patient. when all else fails. And in the purple on the right are the things that essentially, and this is not meant to be inclusive, the things that are essentially going to be talked about at this ASH 2019. This is unbelievable. In the last day, I went to a number of meetings where we talked about the truly triple-class refractory patient. I like the light activity, yes. And we all came up with our favorite thing to do in the triple-class refractory. We'll give them Cytoxan, a little Velcade, little doxorubicin or liposomal doxorubicin. We can go over a lot of these things that we can make up, but they often don't work all that long, really, and the hope is that we get them onto a clinical trial. Now, in the purple, there are, I think, a number of drugs that, in fact, may soon be available for us. Isatuximab, venetoclax, melflufen, belantamab mafodotin, Idacel or BB2121, and then Cartitude, the car with attitude. Okay. So let's talk a little bit about the data. Okay, the first thing I want to go over, and I'm actually going to take pretty much a 10,000-foot view because we all been here a long time. And let's look at IBR, a next-generation IMiD, or a new known as a CELMoDs. And IBR is a next generation from pomalidomide, and you can see here preclinically it has potent activity to degrade Icaros and Aielos, more potent than POM and lenalidomide, so probably more potent cellular cytotoxicity. And then in terms of IL-2 secretion, it increases or enhances IL secretion by immune cells, suggesting that it is a better immunostimulant. So potentially a better drug than even POM and lenalidomide. And with that, it was taken to a phase 1 trial, and Dr. Loniel presented it initially at ASCO and updated it at IMW. This phase 1 trial is in relapsed refractory myeloma. Patients had to have prior len, POM, and a protease inhibitor, and refractory to the latest line of therapy. And in fact, the study has multiple cohorts, but I'm only going to show you the responses for cohort B. It's IBR plus dexamethasone. And here are the data that Sagar presented. And the overall response rate in this refractory population was actually quite good, 32%. And if we look at the IMiD refractory, it was still 35%, and DARA and POM refractory, again, still 30%. So a very potent agent together with dexamethasone. And what Sagar pointed out, it actually seemed to be very well tolerated. If we looked at TEAEs, grade 3 or 4 in cycle 1, no fatigue, no neuropathy, no diarrhea. There was some infection and some blood count suppression. And we'll have to see how that does over time and how the toxicity changes over time. But a very potent agent that we're all looking forward to to combine, to make it a triplet, like that's going to be done in the phase 1 trial, like I showed you. Now, there was a nice question about venetoclax, and I'm going to briefly talk about venetoclax, and that this is a highly selective potent inhibitor of BCL2. And in a phase 1 trial, Dr. Kumar showed that in the patients that have the 11-14 translocation, the response rate is actually quite good. At single agent, 40% response rate. In the non-11-14, it was only 6%. But we know that venetoclax actually could probably synergize with dexamethasone and also with the proteasome inhibitor due to their effects on MCL1 and also on BCL-XL. And so it's probably a potent combination. And Dr. Moreau has done the phase 1 trial combining the triplet, venetoclax together with Velcade and dexamethasone, and showed in a 1 to 3 prior therapy population that was sensitive to Velcade, an overall response rate that was greater than 95%, a very active combination. But a checkered pass with that, right? Because the Bellini trial happened. And I think everybody knows about the Bellini trial. In the Bellini trial, in the all comers, there was an increased risk of death in those getting the triplet versus the doublet of bortezomib and dexamethasone. There was a lot of infectious complications and some cardiovascular complications. Now, the response rate was actually better in the triplet, but it was a decreased survival. And so that was stopped, obviously, by the FDA. Now, the hidden pearl in this is the patients who had the 11-14 translocation, or those that had the BCL2 high expression. And I show on the top left, in the 11-14s, the overall response rate was 90% versus 47%. And in the BCL2 high, 88% versus 73% overall response rate. If we look at PFS, in fact, a dramatic difference in PFS where the PFS with venetoclax plus dexamethasone was 9.5 months and not reached in the triplet arm. And if you look at this hazard ratio, when have you seen a hazard ratio like that in oncology? I don't think we've seen many that are 0.1. I think this drug has significant activity in this population. There are a number of presentations at ASH. Here's one of them. It's an oral presentation, but there are also a number of poster presentations. Go by the posters, talk to the people about biomarker-driven activity in this disease. And so venetoclax is going to be a useful drug for us in relapse refractory, but like Dr. Moreau said earlier, it's got to be then taken to frontline with a randomized trial. Now, selinexor was FDA approved in July of 2019 in relapse refractory myeloma after 4 prior lines of therapy and refractory to 2 PIs, 2 IMiDs, and an anti-CD38 monoclonal antibody. Now, who marked that down on their chart? You never see that, right? It's very hard to tell that. But in that is the indication, which is kind of interesting. And that was made like that due to the STORM trial, where 122 patients were given selinexor and dex, 80 milligrams twice weekly with 20 milligrams of dex, and it showed an overall response rate of 26.2%. I think the benchmark really being over 20%, and a PFS of just under 4 months. And now there's many combinations with selinexor and dex, with proteasome inhibitors, with daratumumab, et cetera. There's many ongoing trials, including a phase 3 Boston trial of selinexor dex versus bortezomib, selinexor and dex. Now, it doesn't come without toxicity, right? Selinexor has some toxicity, and it has some GI toxicity, has some fatigue, has some hyponatremia, and some blood count suppression. You can't just send them out and say, come back in 4 weeks and we'll start your next cycle. These people need to be seen weekly, and you have to follow them very closely. Now, another novel agent is melflufen, and it's a lipophilic peptide conjugated alkylating agent. All right, say that 5 times fast. But the lipophilic component actually allows rapid entry into cells. Cancer cells have are overexpressed aminopeptidases. They cleave the peptide. The cleaved alkylator stays intracellular, then goes into the nucleus and causes traditional alkylator toxicity. Now, there's been a couple studies with melflufen, or a number of studies with melflufen. The initial, Paul Richardson described at ASH a couple years ago in the relapse refractory setting in double refractory patients, looking at melflufen. This was 20 or 40 milligrams IV Q4 weeks. The dosing now is 40 milligram IV Q4 weeks together with dexamethasone weekly. And showed an overall response rate of 31%. It was taken to a much larger trial, the Horizon trial, which Paul updated at EHA and also at the IMW meeting in September, showing in these very refractory patients, 50% were alkylator refractory, 80% were DARE refractory, 62% had high-risk cytogenetics. This is a very refractory population. A lot of them had EMD, extramedullary disease, and showed an overall response rate of 28%. The hope is this data is actually good enough with a good enough response that it may actually allow the FDA to allow us to move forward with accelerated approval. Now, there is a phase 3 trial of melflufen versus POM-DEX in relapsed refractory myeloma, and that hopefully will be potentially a registration trial. And in the last couple minutes, I want to talk about now our BCMA-directed therapy, and that's what that's what a lot of people said that they would go for in this patient that we discussed. So the first one is belantamab mafodotin, or now the easy name Belamaf, a lot easier to say, Belamaf. It's an antibody drug conjugate. The conjugated drug is the microtubule disrupting agent MMAF, and this works by ADCC, by traditional antibody drug conjugate toxicity with release of the toxin. It also blocks BCMA and may provide a cell death signal that way, and some yet to be described immunogenic cell death, which I find very interesting. So the DREAM-1 study was the phase 1 study, and we heard about it from Dr. Cohen and then subsequently in Dr. Trudell. And they had an expansion phase where they treated 35 patients. And this drug, the kind of the unique thing about this drug is there are some adverse events that we don't see with a lot of other myeloma drugs. The most substantial is corneal events happening in about 70% of patients. And thrombocytopenia, about 60% of patients. This is classic for the toxin MMAF, and it's been seen in other antibody-drug conjugates in different indications with MMAF. And so you can bet that GSK is working hard to try to limit this toxicity and also to provide recommendations for us when we are able to use this. There also is infusion-related reactions, but they did not use any steroids as pre-medications. Now here's the response rate. You can see that the responses were deep. The majority of patients achieved VGPR CR or stringent CR with an overall response rate in 35 patients from single agent belamaf of 60%. There's almost no other agent that has had a response rate of 60% in this population. I'll also say that in the DARA refractory, the response rate was, or the DARA exposed, the response rate was also quite good, 38%. And if you look at PFS, the PFS was actually quite good in the study, 12 months, and a duration of response of about 14 months. So now they've done a very large phase 2 trial. We were hoping it was going to be a late breaker at ASH. It's not, but I think you'll hear about it very soon. And that also is a potential to lead to early registration. And there's a number of studies planned, including DREAM 2 to DREAM 10. As you can imagine, they're going to blanket all the drugs in myeloma and see where it's best combined. Okay. Now, what about the bispecific, the BCMA targeted bispecific? And this is the Amgen, the true BiTE from Amgen, which targets BCMA and CD3. And this data initially cracked Twitter, where everything is first exposed these days, in September of last year. And I was sitting next to Keith Stewart, and we looked at each other like, this can't be true. This can't be true that this single agent can do this. Well, let's look at it. We looked at 10 patients that were treated at what we consider the maximum tolerated dose. This is a continuous infusion, 4 weeks in a row, 2 weeks off, at 400 micrograms per day. And in a heavily refractory population, heavily pretreated, the overall response rate was 70%, with 5 patients achieving an MRD negative response. Again, single agent IV therapy. That is pretty amazing. Now, it was continuous infusion. And despite this unbelievable response rate, Amgen has decided that they're not going to go forward with the development of this molecule because of the lack of ease of administration. In fact, what they have a new technology where they bind with the BiTE to this half-life extending molecule and hoping that this actually can be administered on a weekly basis and see the same response rate that they've seen in the earlier studies with 420. Now, they're not throwing it out. It's still in the closet. So if this doesn't work, I think it's going to come out of the closet. But if this does work, then maybe they'll give it to all of us so we can have it in our clinics. Now, my favorite abstract at ASH is actually this one from Celgene. And this is also another BCMA bispecific drug. And it basically has... it's a standard antibody with an Fc component, so it has a long half-life that can be given once a week. But it has 2 binding domains to BCMA on one arm and a binding domain to CD3 on the other arm. And in this, what they described in their abstract, I'll tell you, get there early for this session. In the phase 1, first-in-man study, these patients had 6 prior regimens. They had a number of the usual prior medications for myeloma, and they are refractory to the last line of therapy. So in 12 patients treated at greater than or equal to 6 milligrams weekly dosing, the overall response rate was 83%, stringent CRs of 33%, and if you look at bone marrow MRD negativity, 9 of 12. So what we thought maybe the Amgen one, maybe that's just, it was lucky, it just happened. It's not. This is unbelievable. And there's about 8 or 9 companies now that have jumped in the BCMA space with a bispecific drug. So this is going to get really, really interesting over the next few years. All right. And with the last minute, what about CARs? And so obviously, a few years ago, we said CAR-Ts, is it going to be a game changer? I do think it's a game changer. It is going to change the way we practice myeloma. Where it's actually going to fit in the paradigm of myeloma, that we're going to have to figure out over the next few years. But I'm going to show you some data. The CARs actually differ basically on what they target on their cell surface, the type of gene transfer that's utilized, and also the signaling domain, whether it's 4-1BB plus CD3 zeta or CD28. Now, the initial US study showed a pretty good response rate, 60 to 90%, in really refractory patients. These studies all had 7 prior lines of therapy, high-risk cytogenetics in the majority of patients, with reasonable toxicity rates. CRS, mostly grade 1 and 2 of 70 to 90%, and less neurotoxicity, again, mostly grade 1 and grade 2 neurotoxicity. But the problem with CARs has been the persistence of CARs, right? They haven't been persisting. Now, what about the leading compound is obviously is BB2121, now known as ide-cel. And this is data that Dr. Rajay has presented multiple meetings, but also has published in the New England Journal, again showing at the higher cell numbers, greater than 150 million, an overall response rate of greater than 95%. And it didn't matter if it was BCMA high or low, everybody responded. And if we looked at PFS, the PFS was 11.8 months. But this disappointed all of us, right? Because it's not like lymphoma or leukemia. There's no flattening of the curve. And so there's still work to do. Now, this is the Legend study that was initially done in China. Again, in a less probably heavily pretreated population. The overall response rate, again, 90%, majority of them being CRs and VGPRs. And a PFS of about 15 months. And despite that it was less heavily pretreated, we're still seeing relapses. That again, that concerns us that maybe this is not going to be a curative therapy in myeloma like lymphoma. Now, so how are we going to improve the CAR? Well, we can improve it in many ways, but I'll just say 3 things. One is we potentially have to improve the binding domain. We may need bicistronic binding domain so that when a person relapses, it's not because they lost the target or the antigen on the cell surface. We need to enhance the safety, right? Hopefully we can decrease the CRS, neurotoxicity, and have a safety switch or a death signal in the CAR so we can turn them off if need be. And then we have to enhance the T-cell efficacy, either by bringing it earlier frontline or being able to manufacture more enriched cells for naive T-cells. So my second favorite abstract is actually going to be presented by Dr. Cohen from Seattle and with Dr. Green. And this was their CAR up in Seattle, which is this is a first-in-man study. It's a fully human anti-BCMA CAR. And what they do is they pre-therapy with CAR give patients a gamma secretase inhibitor, and hoping that the gamma secretase inhibitor can increase the expression of BCMA and make it a better target. And they're going to show you data before gamma secretase, after gamma secretase, and then they're going to show you data after they get the CAR. And on this, and in the abstract, I'll tell you, they have showed that the overall response rate for their CAR, and it's in a small number of patients, 6, was 100%. But 2 of these patients had had prior BCMA therapy. One happens to be my patient and completely didn't respond to their BCMA-targeted CAR at UCSF. And the other one is a patient that received a BiTE. So this really excites me also, that we might be able to help by giving patients gamma secretase inhibitor, upregulating BCMA, and making it a better target. Next generation, hopefully we're going to have some off-the-shelf CARs, some allogeneic CARs. Many good advantages to that. The cells are taken from healthy people. One donation maybe can make 20 or 50 CARs, right? Not one for one, but one for many. And this is going to be an ongoing study from Selectus, and it's going to be led by MD Anderson. Okay, so in conclusion, for me, the triple class refractory patients, it's an unmet medical need. We need more options. Our standard options are limited, but we're going to get some new options. Really, in the next year, we're going to have 3 or 4 more on our list to play around with. We have selinexor, we have alkylator-based therapy, and we, again, have these clinical trials that have shown significant activity. And with that, I'll close. Thank you very much for your attention.
Click forward. Yeah, there you go.
Okay, so we're going to go back to the case. I'll remind you of the case. This is a patient that had a 1q21 gain in a 414 translocation, and then has had a number of therapies, including RVD, stem cell transplant, and relapse. So the first one is, let's vote. First question is, I think we have 2 or 3 questions. Maybe we're only doing the first 2. So this is a person that relapses and is asymptomatic in the relapse. He relapses with light chains only that are rising. What do we do when light chains are only rising in a high-risk patient? Do we treat them or we don't treat them? Completely asymptomatic. Do we observe? Watch pace of disease. Do we give them a DARA-based regimen, as you can see? Do we give them carfilzomib? Do we give them carfilzomib Pomdex? Do we give them ixazomib Lendex? Or unsure? Go ahead and vote. I know, I did change it. Yeah, you get change it. Okay, here we go, perfect. So we got a lot of DARA Pomdexes. All right, very good. Very easy regimen to go, a very effective regimen, and was selected by us. Okay, so it looks like DARA Pomdex won out on that combination. Okay, I think we have one more question. So the patient was treated with DARA Pomdex, and after 2 cycles achieves a VGPR. He continued DPD. We had to change the dosing of POM and DEX. I personally take DEX off very quickly because I think the antibody plus IMiD is enough. And then at 9 months, he has a small increase in his light chains, but he has femur pain and has a new lesion in his femur with a soft tissue component. All right, so what are we going to do with that patient? Let's vote. Are we going to radiate the femur and continue DPD? Are we going to go to Carpomdex, DARA carfilzomib Dex, Elopom Dex, Selinexor Dex, or clinical trial targeting BCMA? I'm curious to see what you guys say. I might change my vote too. Okay, so everybody's going to BCMA targeted therapy, which I think is very appropriate in this patient for sure. Very good. So clinical trial targeting BCMA. And I think that's it with our questions.
Okay. Yes. Thank you very much, Tom. So thanks to Tom and Vincent for guiding us through a lot of very complicated options that we have right now, but some fairly simple answers.
Yes.
So, any comments from the panel, or how about questions? So we have a question right here. After we do this, we'll be doing the algorithms. Okay.
I'm interested in your approach in first relapse treatment after a patient had daratumumab in first-line treatment. How would you continue? Would you recombine with other agents, or would you switch?
So good question. If DARA is moving up front, how does that change your choices moving forward? Yeah.
Yeah, and that's where the problem is, because we have very few trials in the first relapse setting targeting patients who have started on DARA or Lendex as their initial, or even worse, DARA bortezomib Lendex, the DARA VRD regimen, and so it's hard. And that's why I basically said, just go with the principles, 2 new drugs at least, and unfortunately the dexamethasone stays, so you have to come up with something. So if they're on DARA Lendex for their initial, they could go to Carpomdex as their first relapse option, and so on. I mean, it's very difficult, otherwise, you're just going to be guessing. So you have to look at what the patient had before, and if they're continuously getting DARA Lendex for 4 years, like in the Maya trial, you'll have to change fully. I wish Janssen will do a trial where if somebody is on DARA Lendex, then they randomize to KPD versus DARA KPD to show that keeping the DARA going has some benefit, because that's another 100,000 per year. If I'm going to do that, I need to show that extra value is there. I wish they will do that. I don't want it to be like rituximab, where we just keep DARA for 5 years, 10 years.
So I have a question. If we're going to be moving to a DARA 4-drug regimen, DARA VRD and the like, and those patients are relapsing, do you see the BiTEs or the CAR T moving up earlier?
Yes, they will.
Tom, you want to comment on that?
Sure. So, at the current time, in some of the data that you've seen, and again, Peter Voorhees will present the Griffin data later this weekend, that these patients are likely going to have a PFS in the 60, maybe 70 plus month range. Okay, so we're making a decision today what we're going to do. We're putting them on DARA RVD. I'm going to tell you 5 years from now, we are going to have BiTEs approved. We are going to have a couple CARs that are approved. And it's probably the next thing is going to be potentially a BiTE or a CAR, and all the rest of the stuff is going to kind of be moot. Now, I will tell you that so there's two things about that. One, when you get a CAR and you get a BiTE and you have a response, patients rapidly have undetectable light chains. There is no therapy that we've ever had, stem cell transplant, high-dose melphalan, double transplant, that has ever gotten rid of light chains. These drugs are getting rid of so many plasma cells, almost all plasma cells, because the light chains are undetectable. That's a big deal. So they are certainly more potent. They debulk the disease better than anything in my mind. The hard part, like in Saji and I have been talking about this light, is infection. What's it going to be like infection? And that's what we're going to find out over time is, can we do that? I do think that with the BiTEs and the CARs, we're going to be able to shorten therapy.
So
Right.
I have a comment to make. We have a lot of people who want to ask a question.
Okay,
So I'm going to...
excellent. So,
This jump...
all right, go ahead, please.
She's telling me to shut up.
We have time.
I'd just like to continue with this idea of DARA continuous treatment. I think the community needs to push Janssen hard to have these trials done, because when we think about the many modes of actions that CD38 antibodies have, it's difficult to imagine that patients can become totally refractory to a CD38 antibody. I think it will add something to any combination it's given with. One thing I was missing in the very extensive discussion of drugs to use in the advanced disease is daily oral cyclophosphamide, which can be very efficient, especially with daratumumab. I think it can do a lot of good things.
Yeah, especially with
So certainly a very simple option that can sometimes add. Yes, absolutely.
Okay, here's my next one.
Just two conditions which are difficult. I want to know the opinion of the panel. CNS myeloma and multiple extramedullary disease.
So CNS is really that's a tough nut to crack. So you have, pomalidomide, or the IMiDs cross the blood-brain barrier. Selinexor crosses the blood-brain barrier. Marabavir, if we ever get it approved, crosses the blood-brain barrier. And you might get a little cross with daratumumab, with the antibody. If they have CNS disease, I usually try to give them everything I can.
Mm-hmm. Okay. So other questions? Okay, number six. Number 6 looks like. Okay, go ahead.
I just want to have your brief comments on Rick Aller considering the autotandem and early relapse setting in the era of expanded armamentarium, especially if you have any other, then it should be an option in the context of a clinical trial. Should we just ignore it as an option or not?
What? Allo. Yeah. Well, so you're going to get a little bit of different opinion on that one. So for a lot of our centers, allogeneic transplant sometimes excludes people from the clinical trial. So we don't do allogeneic transplant unless they have significant cytopenias and no stem cells stored. Then we do the allo just to get a marrow recovery and hope that we can get a trial that'll open up and give them a chance. No, those patients that are treated like that, none of them are cured by allogeneic transplant. So we tend not to do it.
Right. So in Europe, what do you think?
Well, in France, we are not doing allo anymore. I think that we have plenty of options. We have a lot of studies showing that despite allo, patients are progressing, and on top of this, you're inducing toxicity with chronic GVHD. So that's not an option anymore in the French guidelines, at least.
Right. Okay.
Can I also comment, Brian? I wouldn't completely close the door on allogeneic transplant. There are still some patients who have done extraordinarily well where we had basically given up hope that they would ever have any chance of long-term survival. So young patients who have basically exhausted options, who are still in good performance status, who are willing to accept an outside chance at long-term survival in exchange for an unproven therapy with lots of side effects, we have done it. And there are still some patients who are like that, which as of even this year, we have recommended it. And I know that there are patients who have been multiply refractory, and then 10 years later, they're running marathons and doing well, and all of them are allo survivors.
Okay, important points. Okay, other questions?
Any other questions? Meaning alive? No?
No?
There's one over there.
Is there one question
right.
over there? No? If not, it's all right.
Hey, this is Chris Krug. Quick question. What would your maintenance therapy be for 17P, young?
What is the therapy for
17P?
For relapse?
No, just for newly diagnosed, I think.
Just up front, just curious.
So we would use a bortezomib-based regimen or a proteasome inhibitor-based regimen if they got another proteasome inhibitor instead of bortezomib up front. But a PI-based regimen, whether it's PI plus len or PI alone, is certainly my preference. And that's based on the HO1 trial showing, particularly for the 17P patients, an 8-year survival of 50%, exactly the same as a non-17P patient.
Right.
In Dr. Jakubowiak's data with KRD, it included a small number of patients that also had 17P, and they actually did well on that study. So, based on belief, some of us will go with KRD as induction therapy for them.
So how long would you continue Dex for the maintenance, or would you just, what would your thoughts on that?
So the dexamethasone maintenance question, I think in terms of randomized trial, there's one from Italy, which looked at, after the finite duration of induction, len versus len-dex, and they found no benefit to the dex. So even for VRD patients after 1 year, we are now recommending only len maintenance, not len-dex.
All right. Okay, so I think why don't we go into the final session? I think that this year the algorithms are a little bit different. As I said at the beginning, we'll have the US perspective followed by the European perspective. And for the US perspective, hopefully, Vincent, you thought about these answers, okay? So the first one is, I'll just take it, lead you through it, okay, and you can comment. So when should treatment be initiated? Potential new myeloma or smoldering myeloma? And so obviously with CRAB or slim CRAB, treat as myeloma, pretty straightforward. No myeloma defining events, what we discussed in the first session, smoldering myeloma, high risk smoldering myeloma or not high risk smoldering myeloma. For the low risk, observation. I think what we have and what we talked about is for the high risk, we have early treatment with Len-Dex or Rev-Dex or clinical trials. And we had some discussion back and forth about that. So I think that in this case, it might be interesting to see what happens with the European perspective. And I think that maybe, Philippe, you can comment. The thing that you wanted to emphasize is the continued option for observation.
Well, we discussed this point with Jesus. Unfortunately, Jesus is not able to attend the meeting today, but as compared with Vincent, we are just proposing another box, observation for high-risk smoldering myeloma, and we discussed this previously. It's not obvious to treat immediately some patients outside clinical trials. So.
Yeah, and I think as we discussed with what Jesus put up on his slide, it's a shared decision making. You have to discuss the pros and cons, the data with the patients and help them make a decision. Some patients are very uncomfortable with wait and watch. Some patients are very uncomfortable with therapy. And so we have to take that into account, particularly given that they are asymptomatic and your treatment's only going to make their quality of life worse.
Okay. All right, let's move forward. Frontline, newly diagnosed, transplant, no transplant. Do the no transplant first. And I must say, Vincent, this was interesting to me. For the non-transplant, you have VRD for 9 months, which is...
the SWOG trial. Which is the SWOG trial.
Yeah, no.
Which you did.
No. No, it's 6 months.
Is it 6 months?
Yeah.
9 cycles.
Oh, sorry, I meant
He
9
turned it upside down.
You're talking about 9 cycles. Okay.
9 cycles. Sorry.
6 months.
6 months.
Followed by LEN. It was actually LENDEX or DRD. So basically VRD or the Maya trial results, okay? Then for the transplant, you have VRD or a DARA-based quadruplet, and then you have auto stem cell maintenance with a PI-based regimen for high risk, and then only selected patients, VRD, 4 cycles, LEN maintenance, delayed transplant. Okay.
Right. The preferred is induction, transplant, maintenance. That's clearly what we like to do. I'm just saying there are some standard risk patients, selected young patients who really, really want to delay transplant, and for them we are still allowing that option because it's shared decision making again, and we don't have very, very strong overall survival data that early is definitely better than delayed. So we do it. But if you're going to do it, you have to be careful that your facility can collect and store stem cells indefinitely, and that you will do and follow through on the transplant at first relapse.
Okay. So what happens when we go over to Europe? So maybe, Philippe, you can take us through. So on the non-transplant side, you have 3 options, yes?
In fact, more and more we are using lenalidomide frontline in elderly patients. LENDEX is approved. VRD is also approved, followed by LENDEX, according to the SWOG study, your study, Brian. And we are, choosing one versus the other according to frailty, comorbidities, and so on, as we discussed previously. VMP DARA, based on Alcyone, is also approved and reimbursed in some countries, but that's only a second choice, I guess, based on PFS. And, in Spain, Marivi was the leader of the VMP DARA study. So in Spain, VMP DARA is widely used, but not all over Europe. As soon as LENDEX DARA will be approved, I guess that based on the Maya study and outstanding results, we are going to use quite a lot of LENDEX daratumumab. But currently, this is the first choice.
Okay. And then for the transplant candidates, you might lead us through some of the changes here. So obviously, yes, for the induction.
Yeah, for the induction, in fact, VRD is not approved in Europe for induction prior to stem cell transplantation, but in some countries we can use it quite easily, in Germany, in France, etc. And if VRD is not available, we are using VTD or VCD. Quadruplet combinations are not approved, so we have to wait. KRD is not approved, frontline as well, so we need phase 3 trials for the approval of KRD. So here you have the main difference as compared with Vincent is that we are very mostly proposing frontline stem cell transplantation for all patients and no delayed stem cell transplantation. That's only inside clinical trials that we are testing delayed stem cell transplantation. And for high-risk disease, more and more we are using LEN plus PI-based maintenance. We have the experience of the Emoris group, for example, with VRD maintenance in 17p deletion with quite good results. And for all standard risk patients, LEN either until progression or fixed duration of 2 years.
Yeah, so
that's very similar to the US approach.
But a 2-drug regimen in the high risk. The no delayed transplant, that would be predominantly with a triplet, just with a triplet, not with a quadruplet, but perhaps. Okay, all right. So first relapse. Not refractory. I think this is fairly straightforward. Vincent just talked about this, so I think that that's fairly clear. And for the refractory, switching from Revlimid to Velcade or pomalidomide, and the other backup options. I think that's all fairly straightforward. And then for Europe, do you want to comment on some differences there?
Well, DRD, obviously, when patients are not refractory to DARA, when reimbursed and available, is the first option. But in some countries, we don't have access to DARA-LEN, so KRD is widely used, associated with an overall survival benefit. We are using quite a lot of KD, in fact, in Europe as well. And we are going to hear next Tuesday as a late-breaking abstract, KD DARA versus KD, the Candor study. Saad Usmani will present those data, important ones to my opinion. So potentially KD DARA after approval.
Okay. And then for refractory to lenalidomide, obviously,
and when patients are refractory to LEN, very similar to Vincent, VD DARA is a good option. But Vincent did not mention POM-VD, and we are using POM-VD that is approved in Europe based on the Activism study published this year by Paul Richardson. So POM-VD is widely used, and we know that at the time of the first relapse, the PFS of POM-VD is 18 months, so that's maybe a difference as compared with your proposal. Otherwise, that's very similar, but KPD is not approved, KD DARA is not yet approved, but we have these options also from one country to the other.
Okay. So second or higher options, I think, again, Vincent just showed these slides, so I think that you can see what are those choices. And then perhaps I'll just show these together. So the additional thoughts that you would like to add there, Philippe?
Well, we have the ICARIA study for second relapse or later relapses. Vincent showed the slide of ICARIA, POMDEX versus POMDEX isatuximab. Probably it will be the first approval of isatuximab in combination with POM. Otherwise, well, clinical trials always, if available, for sure.
So that they can have access to the slides.
Yes. Yes, yes. Okay. All right. All right, let's see what we have. Okay, so those were our last choices. Shaji or Tom, do you want to talk about any issues on those algorithms? Tom, are you, and Shaji, you're solidly US, you're not shifting to Europe?
No plans. I think it kind of goes back to this is going to become more and more challenging as we have more drugs. I think sticking to that principle of changing classes of therapy and always using drug combinations is going to be the principle that will stand the test of time. It doesn't matter what drugs come and go. I think those principles will continue to be important. The second thing we don't know much is what is the impact of. We know the MRD is prognostic in this patient population, but in the relapse setting, some of the same principles that we are currently studying in the upfront setting also need to be applied in the context of clinical trials. When do we stop therapy? Many of these trials have been designed to be continued till progression, but I'm sure there are patients in whom we can discontinue therapy based on depth of response.
So one point I just wanted to emphasize that came up, those slides that you saw at the end and all of the other slides, they will be available online. So you will have access to those slides, okay?
The only thing I would also mention is as our therapies get better, and they really are getting much better, obviously, we do need to be able to do exactly what Vincent's been saying, is to be able to take people off therapy. And so we have to use our best ways to measure disease, especially using MRD. And so let us do that at the academic centers and clinical trials and figure out how to measure it and then what to do when we find that measurement. And is it going to be 6 months MRD negative or a year, and then how to change therapy. But I do think that over time, hopefully we're going to be able to go with limited therapy rather than in somebody's 10-year myeloma history, they're on therapy for 8 out of those 10 years. Maybe it can be a lot less than that, which would be great.
Okay, well, thank you. So we've had a lot of information this afternoon. I don't see any arms rushing to be raised. So with that, I would like to thank our panel, our expert panel, for fantastic presentations and discussion. And thank you to all of you for being here. I hope that you found it worthwhile. And the slides will be available soon. So thank you.